Good morning and a very warm welcome to all our esteemed guests to this annual Evercare Health Conference 2025. Karibu sana, Kenya. Khush Amdeed, Pakistan.
And to the Nigerians, Sanu Dezua, Ndeu Ekabo.
We are your hosts for today and tomorrow for the Evercare Healthcare Conference 2025. My name is Saba. I am the Group Head of Legal and Compliance, and we will be looking after you for the purposes of today. So this is my colleague, Abiodun.
I am Abiodun Rabiu. I oversee the Evercare Medical Center in Banana Island.
So yesterday we had some amazing discussions on healthcare innovation and transformation. Let's keep that momentum going today. Let's be engaged in discussions, let's participate, and let's try and do whatever we can to think about the next steps of healthcare.
And for today, we've got a lot in stock for you. We're going to be looking at some leadership discussions, patient safety, staff engagement, and all of that. And before we move into it, I would like to keep everyone abreast of some of our housekeeping. So to your left, now you have the washroom, and to the back, just behind the backdrops, we have 2 dining rooms. At lunchtime, you're going to move to the centers to have your lunch. We're going to be having ushers around to set your pace. And also we've got, just in case of emergency, we are not expecting any, but just for in case we have an ambulance and a paramedic standing by, just for emergencies. Also, we have exits. In case of any unforeseen events, we have an exit here, then we have 2 exits at the back. And also, behind the tag you're wearing, you have the barcode you can scan to get the full details of the events. And also, not to forget our streaming audiences. We have some people joining us on YouTube and online. You can go, if you want to pass that to anyone, they can go on Evercare website. The link is there to join. And also, we have the Wi-Fi provided for everyone. Just search for the Wi-Fi. You're going to see EHC 2025-123. The password is Evercare, capital E. Thank you.
I'm now going to welcome on stage someone who none of this would have been complete without, someone who without the vision wouldn't have been able to deliver this healthcare conference today. The group CEO, Mr. Irfan Khan.
Good morning. Thank you, Saba and Abiodun. Good morning and welcome to Lagos, a city of movement, resilience, and possibility. A city that reflects the spirit of emerging markets, confident, restless, and determined to shape its own future. We have gathered not only to learn, but to build. Not only to speak, but to act. Not only to imagine the future of healthcare, but to prove that emerging markets will define it. Before we go further, I want to recognize the leadership guiding this conference. Dr. Ayo Shonebare, the conference chair, and Dr. Asad Mia, the conference co-chair. A round of applause for them, please. Dr. Ayo, Dr. Asad, thank you for your steady hands, clarity, and purpose. And to every colleague in Kenya, Nigeria, Pakistan, and here in Lagos who has planned, prepared, traveled, trained, and supported, thank you. Your work has made this possible. Leadership is not delivered on stage, but it is built in quiet hours long before. Yesterday, our pre-conference sessions set the tone. Practical learning, simulation, focused groups for human experience and culture, investor pitches where we saw the amazing talent in all our countries. Real skills, real teams, real commitment to patients and people. That is how a movement starts, one deliberate action at a time. Today, we continue that work. Human Care X by Evercare is our belief that humanity is not soft, it is strategic. Our strength comes from empathy, precision, and accountability. Care begins with presence and dignity. Our academy builds leaders who know that trust is never created by titles. It is earned through behavior, consistency, and the courage to decide when it matters most. It is shaped by a growth mindset, one that learns, adapts, and stays curious. And we also recognize that no organization can do this alone. Our partnership with ECAP and our trainers, Dan, Samir, Maria, and Reem, has shown what collaboration can achieve when purpose meets expertise. What we have built together is not just a program. It is a model for how future academies across emerging markets will look and lead. The E3 Hub, and we saw some innovation yesterday around our E3 Hub, empathy, excellence, and equity, turns ideas into systems, evidence into practice. It is where emerging markets innovate for themselves and for the world. And today is very special because we launch what I call the Emerging Markets Health Exchange, the EMHX. It's a platform of shared knowledge, shared investment, and shared leadership. No charity, no dependency, but capability, partnership, and confidence. We will sign the Lagos Pledge, our shared commitment to build a future where healthcare is designed for and led by emerging markets. And this is not just symbolic, it's the start of a movement. If you believe in this transformation, make it visible. Go to the wall in the back of the room and sign your name and leave your mark. Let Lagos remember that you were here at the moment this new era began. Over today and tomorrow, expect clarity, expect debate, expect learning. Sessions on leadership, digital health, sustainable care, frontline empowerment, women in leadership, governance, and patient experience. These are not just presentations, they are working sessions. We are here to build and not just observe. We stand here with pride, but also perspective. Our hospitals run because our nurses, doctors, technicians, and frontline teams serve long before strategy is discussed. We lead because they show up, not because we stand on stage. I speak to you as a CEO, but also as a student, still learning daily from every patient and every caregiver who reminds me why this work matters. I want to acknowledge the many students in this room from across medical and nursing schools in Lagos, whom we have facilitated to join us, but who have shown immense excitement to be with us. You are the future, and I'd like to give them all a round of applause. This conference is about service, not spotlight, responsibility, not recognition, impact, not applause. If we leave Lagos with deeper humility, stronger conviction, and a clearer path to serve our patients and communities, then we have succeeded. And so, with gratitude and purpose, I declare the Evercare Healthcare Conference 2025 officially open. The future of healthcare begins here, with us together in Lagos. Thank you.
Thank you, Irfan. I would now like to call on stage the chair and co-chair of this conference, Dr. Ayo and Professor Asad.
Good morning, everyone. Welcome to our vibrant city of Lagos. And apologies for actually starting late. I'm a man of a few words, people that know me. This has been a great initiative. We've been at this for some time, and I'm actually happy to welcome you all. The theme of the conference is Connected Care, Transcending Borders. And so we do have a lot of challenges in our market, as you all know. Our markets are very similar. Kenya, Pakistan, Nigeria, we're facing the same issues. There's a workforce shortage, supply chain challenges. We've got underinsurance, we have fragmentation, so many problems. So the essence of this conference is to connect, engage, communicate, interact, innovate. What else is there in ChatGPT? So the healthcare of the future, in my own vision, is digital and mobile. There's no going back. We're going to be able to sort out all our problems, majority of our problems, with this gadget right here. Other industries are doing this. Healthcare is just slow. But with AI, we're going to be catching up, and I don't have any doubt about that whatsoever. Hospitals of the future will be for major interventions, critical care, emergencies, but the day-to-day high blood pressure, diabetes, and chronic illnesses is all going to be here. So let's come together. Let's find a way of brainstorming. How do we make that happen? The young generation of today, in all our markets, you're talking over 60% under the age of 30. So that's the youth. They're going to need healthcare as they grow, and they will be the ones that will actually solve the digital, the technology. So this is going to be really exciting. We're going to continue to interact, engage, and learn from each other, and share knowledge. And please, this journey is about to start today, and we need to continue to ensure that it goes on. So this is an engagement. It's a connection. It's not just a one-off coming, bye-bye. Thank you.
Good morning. Hi, everyone. I didn't know I was supposed to speak, but after all the great words, I don't have much to add. I do have a sincere vote of thanks for Irfan, because he really got us going. And under the fantastic chairmanship, or chairship maybe, of Dr. Ayo for this particular conference, I'm learning how to do it in a very different environment as well. So thank you to both of you, and I'm here to learn. I hope everybody else has a fantastic time. Thank you.
Well, sorry, I dropped a ball there. Thank you, Efren, because I forgot that. The reason why I'm saying this is 8 months ago, we started planning this, and there was quite a lot to do. Now, Efren's approach is completely different from my approach. I'm a kind of a softy. He came in about 6 weeks into the game, and he set up what I would call war room with several battalions. And honestly, those battalions, a lot of them are in the room. Thank you. battalions. And that's what got us here today. So thank you. Now, I'm going to welcome the Honorable Coordinating Minister of Health and Social Welfare, Professor Ali Pate, ably represented by my good friend and brother, another professor. I need to go for my own professorship. Another professor, Wasiu Lanre Adeyemo, to actually give the keynote speech on behalf of the coordinating minister. Thank you.
Good morning, distinguished ladies and gentlemen. The group CEO, Evercare, and the chair of this conference and the co-chair, distinguished leaders and stakeholders in healthcare. I must also recognize the Director General and CEO, NCDC. I represent the Honorable Coordinating Minister of Health, Professor Mohamed Ali Pate, who is not able to attend this very important conference. He's presently out of the country in pursuit of a global collaboration to transform our healthcare in Nigeria. But he has asked me to represent him. I'm Professor Wasiu Lanre Adeyemo, the Chief Medical Director, Lagos University Teaching Hospital. Distinguished delegates, esteemed colleagues in global health, ladies and gentlemen. It is with deep honor and a profound sense of responsibility that I address this gathering today, Evercare Health Conference 2025. We convene at an important moment both for Nigeria and global health community. Our theme, Connected Care, Healthcare Transcending Borders, is a call to reflection and a rallying cry for innovation, collaboration, and renewed commitment. Permit me to begin by recalling the foundations upon which our health system was built. In decades following independence, Nigeria's health sector was recognized as a beacon in Africa. Our teaching hospitals, like UCH and LUTH Lagos, were regional centers of excellence, attracting patients and trainees from across West Africa and beyond. The primary healthcare system, pioneered under the leadership of Professor Olikoye Ransom-Kuti in the 1980s, brought essential services to rural communities, dramatically reducing infant and maternal mortality rates and controlling outbreaks of infectious diseases like smallpox and polio. Nigeria's expanded program on immunization in the 1980s and 1990s achieved coverage above 80% for key childhood vaccines, a feat that contributed to significant reduction in vaccine-preventable diseases. These successes were the result of visionary leadership, dedicated health care workers, and the unwavering support of our communities. Today, you must acknowledge the formidable challenges confronting our health care system. And this included, but not limited to, 1, inadequate infrastructure. A substantial portion of Nigerian health facilities require renovation, and some lack adequate basic essential amenities such as water, electricity, and modern equipment. The second one is human resource gaps. Nigeria has a doctor to population ratio of approximately 1 to 5,000, which is far below World Health Organization recommendation of 1 to 600. In spite of the gaps, the country loses hundreds of doctors, nurses, other categories of healthcare workers annually to migration, otherwise called JAPA. We also have a funding constraint. Healthcare expenditure as a percentage of GDP remains below 15%, falling short of Abuja declaration target, while out-of-pocket payment for patients account for over 70% of total health spending. Disease burden. Nigeria bears the world highest malaria burden, accounting for 27% of global cases. It is also among the top 10 countries for HIV, AIDS, and tuberculosis prevalence. In addition, non-communicable diseases such as hypertension and diabetes are on the increase. About access and equity. Rural and underserved population face significant barrier to care, with maternal mortality rate in some states exceeding 1,000 per 100,000 live births, compared to the national average of 512. We also have issue with governance and coordination. Fragmentations across federal, state, and local levels and weak health information system impede effective policy implementation and resource allocation. Ladies and gentlemen, in spite of the aforementioned challenges, our vision as a ministry, in line with the mandate of the President Bola Ahmed Tinubu, is clear, and that is of resilient, equitable, and efficient healthcare system that delivers health coverage and meet the needs of every Nigerian. Therefore, we aspire to achieve the following as a government. 1, a global standard in service delivery, patient safety, and health outcome aiming to reduce maternal mortality to less than 70 per 100,000 live births by year 2030. Harness technology and innovation to expand access, such as through the National Digital Health Strategy, which seeks to provide electronic health records in all tertiary hospitals by year 2027. We also intend to build a motivated, well-trained healthcare force through expanding training, improve welfare, and incentives for rural services. We also want to ensure sustainable health financing by scaling up basic healthcare provision fund. We also want to foster a culture of research and data-driven decision-making by strengthening institutions like Nigeria Institute of Medical Research. Distinguished participants, beyond aspirations, we are working hard and are getting results. The Federal Ministry of Health, in collaboration with state and local government, is implementing transformative initiatives, which include 1, primary healthcare revitalization, human resource development, health financing reform, digital innovation, disease control and surveillance. The Nigeria Center for Disease Control and Prevention, NCDC, has established a national network of molecular laboratories enabling rapid response to outbreaks such as COVID-19, Lassa fever, and cholera. Quality improvement. National standards for facility accreditation are being enforced to elevate the quality of service delivery in our healthcare centers, including private hospitals. Memoranda of understanding have recently been signed with 2 healthcare quality organizations, Farm Access and Society for Quality in Healthcare in Nigeria, to assist our hospitals move up the rungs of healthcare service quality. Unlocking the healthcare value chain. This is aimed at boosting local manufacturing, reducing dependence on imported medical products, and creating jobs within the country. The presidential initiative for unlocking the healthcare value chain is spearheading effort to curb capital flight from medical tourism and drive economic growth in health sector. We also intend to fix the recurring power problem in our hospitals, that is electricity challenges. A summit on national dialogue over power for healthcare sector in Nigeria was held in September 2025, and the country should expect a significant positive shift in the narrative around the power situations in our public hospitals. Esteemed healthcare stakeholders, we recognize that the government alone in any country cannot achieve these ambitious goals. Because the private sector is an indispensable partner bringing investment, expertise, innovation, we are bringing on board private sector participation such as public-private partnership, local pharmaceutical production, healthcare technology startup, and engaging more of our citizens in diaspora. We are providing an enabling environment for the private sector to thrive in the country. We give tax incentives and regulatory reforms, which have the potential to attract new investment in diagnostics, hospital constructions, and other areas of health sector development. In conclusion, as we look ahead, I am filled with great optimism. The challenges before us are huge, but our resolve is more formidable. Nigeria's healthcare sector managers, health professionals, and all partners are demonstrating unprecedented commitment, resilience, and ingenuity. With unity of purpose, strategic investment, and unwavering focus, we can reposition the future of healthcare in Nigeria. Ladies and gentlemen, let us seize this season to build a legacy of quality health system and prosperity for generations to come. The world is watching us, and together we shall not fail. I wish you all a successful conference. Thank you very much.
Many thanks, Professor Adeyemo. Okay, I'd like to mention there is a medical booth just outside. You can do your vitals, check your wellness. And before we also move on, I'd like to recognize some of our sponsors: ECAP, Tannis Engineering, DP World, FCMB, Leadway Health, Axiom Mansard, Stanbic IBTC. We proceed to call on the senior health specialist, the World Bank, to give his keynote address. His name is Dr. Olumide Okwonla. Please welcome him to stage.
Hello. Good morning, everyone. It's a pleasure to be here. Also to acknowledge the amazing work that has been put into this program. I got my letter of request to participate in this conference in early June. And I never thought about it. But then I got reminders every month. And I couldn't ignore it. And it just so happened that I needed to also travel about this time. But when I recall that I had first gotten a text from Dr. Shodibare and then the monthly reminders, then I knew that, look, this is a serious matter. And it was just something I needed to show up. So very well done to you and your team, sir. And I believe that, trust me, little things like that probably also gives you an insight into the quality of the processes that happens in the facility itself. So, you've challenged me with a very interesting topic, and it's a topic that is actually very close to my heart. And this is going to be a kind of family meeting. Allow me if it's okay, to just talk from the heart. I know Dr. Idris is here. He's DG NCDC, Professor Adeyemo, so there are government people here. But we could either have a discussion where we come up with tangible outcomes, or we just have a show and everybody goes home. So I think we just want to make this worthwhile. So, because I talk a lot, I'm bringing up my conclusion slide, just in case I'm unable to go through the slides. In the course of this presentation, I hope you'll be able to pick that Thailand, the healthcare sector in Thailand, is a major contributor to economic growth. So it's not just a social service, it's a driver of the economy. Philippines, I think someone already mentioned that, it's making deliberate, intentional investments in human resources for health. It's exporting human resources for health, contributing to the economy, planning, but at the same time also achieving universal health coverage. India has become the pharmacy of the world. Everybody knows that. But it was because of deliberate and intentional policies. Kenya, very interesting topic. I've been there thrice this year. They've set up an innovative digital health agency. It's new, but without it, digital in health will remain fragmented. Different countries are taking different approaches. Some are institutionalizing digital in health insurance agencies. Some are institutionalizing it in Ministry of Health. Some are institutionalizing it outside of the health sector and what they call Ministry of Communications. Unique, innovative approach in Kenya. But the fundamental of all of this, the necessary condition, whilst all the above might be sufficient, the necessary condition is how a government considers its people. If your people are important to you, you prioritize your money for your people. So that I am clear, if there's only one thing that you take away from this talk, without the money a government spends on health, universal health coverage becomes poetry. And no amount of private investments can be leveraged without public financing. So let's go into it. So you can stop me. That's my summary. Now, let's go with the flow. So, growth markets. Look, you have a choice. You could decide to invest in economies that are growing at about 1.2, 1.4%, or just the global average of about 3.2. But then there are also some other countries that are powering up in terms of economic growth. South Sudan, Libya, Rwanda, Senegal, Ethiopia, growing at above 6%. And these are the kind of fundamentals. This is where you start from in terms of making an investment. So these are countries that are broadly, you could classify as growth markets. Because as you see, we could classify growth either geographically or sectorally. But in terms of geography, and Nigeria is not doing badly too, implementing aggressive macro-fiscal reforms. And we'll talk about that towards the end of this presentation. Growing 3.8 now, 4% growth, and with surging revenues. So not bad. Below the high-powered South Sudan, Libya, of course, you also have oil and gas investments driving those growths. The good thing, and this is why I wanted to show what's contributing to Nigeria's growth. Before, it was largely oil and gas. Now, it's more about services. And a couple of things there to interrogate. Because when services is contributing to your growth, then the kind of manpower that you require is slightly different. And more so for our sector. So a lot to unpack there. But bottom line, Nigeria is also in that solar, modular perspective of a portfolio investor sitting somewhere in either London, New York, Geneva, investing in this kind of growth markets, like I said, comes with its own risk, isn't it? In the course of this talk, I won't be a lot more opportunities. But, and you can see even some of the investments made by my institution, hospitals, whilst the investments in pharmaceuticals and all of that is still on, but increasingly you're seeing things in service delivery points. And of course, yes, you're right, you're going to also begin to see increased investments in digital. But these things are not automatic. And those are the kind of things that I would somewhat expatiate on. In summary, we can see that there is a direct correlation between healthcare investments and economic growth. And I think it's just important we lay this out up front, because our leaders are under a lot of pressure. Before now, we go and make a case for financing because of mortality indices. If you make a case because of job creation, because of resilience, you probably have a better chance. So don't let's cut ourselves, shortchange ourselves, but position healthcare for what it is, as you can see in the story of Thailand. This is medical tourism contributing, pre-COVID, more than 1% to the GDP. Same thing in India. Just medical tourism, service delivery, not even pharma. So there's an opportunity in this connected market story. So let's take these things one after the other, and let's start with this. Personally, this is my most important slide. This is the population pyramid for Nigeria. You could interpret this population pyramid, because I have 4 points to make from this slide. You could either leverage a dividend from this, or you could actually end up with disastrous outcomes. This chart indicates a number of things. First, before we take Nigeria and several other African countries, an investor in healthcare would look at demographics as a driver of all of the growth that we've talked about. If the person is in the global north, we'll say, look, my population is aging. So my business case will be driven mostly by chronic illnesses. The kind of service delivery models will focus more on, look, how do I do home care services? What sort of professionals do I need to get in terms of having health assistants who can treat from home and things like that. That's how someone would look at the demographics. Here, several things jump right at us. We would look at the service delivery model, because, like, again, we've heard, there's going to be, and we're seeing it already, as you see in my next slide, there's already a surge of NCDs, and unlike Europe and America, where people are getting older before they get those chronic illnesses, here it's coming up a lot earlier. It even gets worse. You're having hypertension, you're having diabetes, and the country is not even spending anything on it. So it's almost a death sentence. So, but that's even besides. For me, the big point here is, if healthcare is a huge source of growth, then we need to see how we can position this population to provide and fill the market for healthcare jobs. Give me 1,000 nurses this afternoon, they can get into Europe tomorrow morning. Every single of them. Bottom line is there's a market and we have that base. Of course, there are other regulatory policies that needs to fit into all of that. But we need to be deliberate and intentional about how to convert this powerhouse into our first opportunity. So it's not just even for the jobs agenda. Without it, our universal health coverage aspiration will become and go largely unfulfilled if we do not address this. But it's also important to emphasize the do-nothing scenario. Today, 70% of our population, they're under 30. Guys, that is a nuclear bomb if they don't have jobs. I just need to emphasize this. There's both an opportunity, a dividend to be reaped here for healthcare in particular, but the solutions lies in our fundamental investments in primary healthcare so that people can get into schools and be able to do well in things like STEM. Again, I think the minister's speech has already alluded to the fact that there's a gross shortage of human resources of health, either in terms of nursing, midwifery, or specialist staff. But I believe if we are able to take the advantage, just looking at some of the back of the envelope calculations that people do in making estimates, a doctor can actually end up having, for one doctor, you have an additional 6 jobs. So that's huge. So this is a sector that should get the attention of our governments, like Philippines. The production of nurses in Philippines varies with the market in the United States. And they've somewhat perfected the art. In a connected world, human resources for health is something we need to pay attention to. So let's look at the pharmacy of the world. ACTA. This is meant to connect Africa. If I want to either travel to Congo, Brazza today, or a few countries, even in West Africa, there are connections that are even easier to go through Europe. If I'm going to travel to Arusha, it's going to take me the whole day. Either going through Nairobi or I'm going through Addis, it's pain. So we do not trade amongst ourselves. ACTA provides a huge opportunity for us, but whilst the opportunity is there are things that needs to be done. And I just give the example of pharmaceuticals. So a lot of, almost 600 manufacturers on the continent, most of us doing finished drug formulations, fill and finish, okay? So pretty much this is a summarized chain of making a drug. The key starting materials could be from plants, could be from bios, or it could be from the petrochemical industry. 10 minutes away, there's that petrochemical industry making the key starting materials for the APIs. Just go down that road. in 40 minutes you get to the Dangote refinery. There's the element petrochemical, making the key starting materials. There's not a single plant in the country today making APIs. None. Whilst there's a focus, and we've cracked the code for finished drug formulations and fill and finish, amongst other things, but the value is going back in the value chain. And we saw when COVID hit how Pakistan wouldn't sell to us, India wouldn't sell to us. No one was going to sell to us. And we were scrambling. So this, by the way, is not necessarily an investment decision, but it's also a decision where you have to price in resilience to say, what if COVID hits tomorrow? What do I do as a country? There are also other things around med tech and other life sciences products. But of course, as you can see, without the Indian market, the generic availability of generic drugs in both the UK and the US will become problematic. And that will drive the cost of care, which is already reeling under high expenditures already. But two quick examples in terms of what a country like India has done, which we would need to take seriously. Countries like India, Nigeria, Pakistan, these are large federal countries. And you have to deploy public financing to stimulate the private capital. Otherwise, we'll just be talking in conferences. You need to have special economic zones that would allow us to have plug-and-play API parks. The Lagos-Shagamu Expressway, huge number of pharmaceutical plants. Put up plants there. Because things like the central effluent treatment plants, so individual countries don't have to, companies don't have to do that on their own. Or you got to bring in incentives into this. Otherwise, this is not going to happen. My favorite topic, because I think if we're going to leverage and harness the potential of youths on the continent, there are certain fundamentals and foundational things that needs to happen. I see a whole lot of energy across the continent. People are innovating in the sector. Sadly, all of those innovation is not going to go anywhere without having the foundational infrastructure. So, Dr. Ayo, I heard you. The future is mobile. But that future cannot be mobile. Mobile becomes useful because the mobiles speak to each other. Mobile becomes useful because there's an exchange that is regulated by somebody. We have money flows on mobile because there's a central bank that does the regulation, that harnesses the data. Without doing that, we may want to try and self-organize. It might happen in 100 years, but it would take too much time. The cost will be too much. We don't have that kind of time. And more so, in healthcare, there's certain things that are foundational. How do you transmit patient data without being sure that all the privacy regulations are in place? So the energies of our youthful population that will be able to drive this without having the kind of setup that's going on in Kenya. Interestingly, the Kenyans are even fighting it, the Digital Health Agency. I don't know where that is now, but it's somewhat putting in place the necessary infrastructure. It is when you have that infrastructure that 5,000 apps will come out of it. So many apps will come out of it. But there's got to be the policy framework that binds it together. There's got to be the infrastructure, just simply even having interoperable codes. That is what will lead to growth. And we don't all have to follow the Kenyans by setting up the Digital Health Agency, which somewhat came out of the National Hospital Fund of Kenya. You know, we could go the Indonesian route, or we could go the Indian route through the National Health Mission, the ABDM. So there are different pathways. But this is one area where there's a role for government, and we need to hold government accountable. So, as I come to the end, I probably should emphasize for me, this is something that I think is at the heart of it all. And without a government, no country has been able to achieve universal health coverage without public financing. And that's where you have outliers like the United States, but then you have countries like Canada and many other countries, even in the global south, who in Ghana today, you can't take away the health insurance program because it's enshrined into the system. I'm sure we have some Pakistanis in the room who can tell us, you know, the progress made with the Setu Sehat or the Universal Coverage Scheme of Thailand. But perhaps I would talk about the Thailand experience. See, our populations, because we have similar socioeconomic characteristics. There's a large informal population. It's your choice. You could decide that you want people to contribute. Okay? That will take a lot of time, a lot of effort. People will drop out. Or you might want to go the Thai route that also tried the contributory pathway and just simply abandoned it, and then took the money off tax contributions collected and paid for everybody. The choice is yours. Okay, even if you don't want to do anything, that's okay. Can you even take some money from what you have made and cover the most vulnerable and the poorest? I can assure you something today. If the latest figures coming from the World Bank, which everyone is quite aware of in Nigeria, in terms of the poor and vulnerable population, and the government is committed to covering those, Evercare will need to grow 10x. We will need much more service delivery providers because that population is covered. And in fact, that is what would allow us to be able to deliver certain complex procedures at scale. Because if you are able to deliver to a whole large number of people, then you will benefit from scale. So this is not just, these are decisions that needs to be made and needs to be made right now. Let me close with Nigeria. That's the president of Nigeria. Federation, bringing all the governors together, signing a compact to say, okay, look, we have agreed that health outcomes are poor. So we will now dedicate public financing for health care. This was signed in December 12, 2023. And that's their signature. So saying across all countries, the first thing is about political commitment, which we got here. Then even life became a lot easier because like I mentioned, the macro-fiscal reforms was just amazing. And our state governments in Nigeria's federal system, we began to experience amazing and unbelievable revenue surges, which means that whilst, yes, there's still fiscal constraints, but today what the data is showing is that actually our governments, either especially at the sub-national level, can actually cover and pay for healthcare for their people. I think that point is well made. There are learnings and lessons to learn from other large federal countries, but I think I just want people to go away from this meeting noting that with our current state of spend at about 0.5% of GDP, which is perhaps one of the lowest known to mankind, for the level of Nigeria's wealth, it's unacceptable. It will not take us to universal health coverage. And without addressing that, then fine, beautiful hospitals, facilities like Evercare would only be available for those who can afford it. For a nation and country that is aspiring to become a $1 trillion economy by 2030, healthcare has to be part of that equation. It's not just a desire, it is consequential to provide jobs for the youthful population. It is, in fact, what will make Nigeria competitive. Thank you very much, ladies and gentlemen. Sorry? Really?
Thank you very much, Dr. Olu, for a wonderful speech. Big round of applause. If I can just call our group CEO to hand you an award.
Thank you, sir.
You're very welcome. Thank you.
The look of love is in your smile can't disguise the look.
And to welcome our next guest on stage, I'd like to call Dr. Ayo.
Words could ever say, and what my heart has heard when it takes my breath away, I can hardly wait.
Yeah, thank you very much, Dr. Olumide Okunla. Every single time I listen to Dr. Okunla, what I remember is some of the professors in uni that I've lectured. His delivery is always professorial. Thank you. We really enjoy that. Now, I didn't have my cup of coffee this morning, and therefore I want to apologize to my good friend and senior brother sitting in front, esteemed, distinguished Director General of Centers for Disease Control, and everybody remember Ebola, COVID? That's the man that saved Nigeria from those two pandemics. Thank you very much for all the work that you've done. and you continue to do all this great work. So please welcome Dr. Jide Idris to deliver his lecture.
Good morning, ladies and gentlemen. Let me first of all express my appreciation to the organizers of this event for inviting me, especially Ayo. Just like Olumide said, Ayo harassed me almost every month. As late as 2 weeks ago, Jide, are you still coming? I said, I think so, but I will try to come. But I had no choice but to be here anyway. Let me also say that contrary to what we're all talking, aside to what we're talking about, I had a discussion with Lumide just this morning. He's a professor. He likes all these figures. I'm not very good into figures. But the point is that he said we should all be practical. And let's be realistic. I'm very happy that I included this topic, which is connected health, cross-border health, cross-border disease control, and some people might even call it migration health. Because my take is that in all we do in any country, especially in this country, most times our focus has been largely based on infrastructure. I'm not saying that what the private sector is doing, what governments are doing are not right. Yes, it's good to have infrastructure. But the problem is that infrastructure, your healthcare facilities and all, to me, they all contribute just about 25% of the health sector. If we do not address public health issues, we will continue to lose people. And the evidence is very clear there. So this is just my, my context, the content of my presentation. This slide is coming it's coming too early. But basically, just to say that these are the risks we envisage globally here. We have globally. The global threat to infectious diseases. Globally. But every single factor we have, like new and emerging pathogens, nature of diseases, urbanization and globalization, environmental factors, fragile health systems, populations, as they also occur in Nigeria here. They feature very, very much so in Nigeria. In terms of cross-border health, and let's not look at cross-border health as transnational, let's look at it both transnational and national, and subnational, because I believe that if you can get our acts right nationally, I think we're prepared for any international public health emergencies of international concerns that we may likely face. They say that we live in an increasingly interconnected world where pathogens know no borders. It's guided by movements of people, goods, and livestock across boundaries. So if we do not recognize this and strengthen our system, we're wasting our time. Like Ayo said, Ebola was an example. You know how the man came from somewhere, from Sierra Leone. But again, for 6 months before Ebola came here, we knew of Ebola was ravaging other countries globally. That was in 2014. And COVID came a couple of years after. It was these two events that made us realize that our health system is extremely fragile, very weak. And no matter the number of people we save in the hospitals, this kind of epidemics can wipe out people, all within a short period of time, within far in excess of what we see in hospitals and all. So that's why let's be realistic on this. And that's why it's essential to look at public health. I know a lot of diseases we see as emergent infectious diseases, as zoonotic diseases, diseases of animals that find their way into humans. This one is a list of the threats we face in this country here. The national risk, of course, national risk of concern. Intricate threats, population size, I think Olumide mentioned a lot about it. Air pollution, food, water, environment, poverty, etc. Look at endemic threats. Most of these is a Lassa fever are occurring in this country right now. We are managing about 10 outbreaks nationally at NCDC. Here they are. They have your border transmitted disease, they're all related because a lot of this is cross borders. Lassa fever is one, cholera is one, meningitis, measles, diphtheria. In fact, virtually all of them, they cross borders, both transnational and national to states. And of course, we have climate change, human security threats, conflicts and terrorism. These are threats to our public health systems. This is a map of Nigeria here. Virtually all states in this country have one outbreak or the other. All states. That's the map there. And of course, they say, well, look at our borders, national borders. In this country, we have land borders, about over 4,000 square kilometers of land borders. Very porous. Extremely porous. And we have about 114 points of entries, both land, airports, seaports that we can cover. All the other ones, again, people just walk across, both internationally and nationally. And what facilitates them? Trade, hotspots, livestock, corridors, animals moving from up north, down south. And I give you an example for Mpox when it came up. We were lucky, the incidence is still going up, but at a low rate. And the Cameroons next to our borders on the left side, they've seen the clade 1 and clade 2. Luckily in Nigeria, we have clade 2. Our problem is that we should not allow clade 1 to get in. We must protect ourselves against clade 1. That's why it's essential that we need to be vigilant. Trade, livestock, etc., points of entry, people moving in and out. I remember when I was doing Ebola, some of the CDC staff, where they went to the border to go and check what was at the border, they didn't know they had crossed the border to the other country because they just kept on walking. And they moved to Togo or Lome, whatever it is. So, the other issue is that let's be holistic. Because when we talk of cross-border, we will generally think of infectious diseases. But non-infectious diseases are also key. One, because any non-infectious disease like cardiac disease, etc., they affect our vulnerability as a people. If you look at it from the point of view of lifestyles, smoking, tobacco, they're all part of trade that come in here. They affect these people again. And if care is not taken, more people die of these non-communicable diseases and also affect our ability to respond to threats, especially when we need such stuff. Because when these infections overwhelm our capacity, we have to start relying on other people. So let's not look at border issues as only infectious disease. It also involves non-communicable diseases. Now, our mandate in NCD is health security. And of course, our job is to prevent the population from any threats by preventing threats, detecting and responding immediately. And how do we do this? Are these components there? Prevention, mitigation. When I got into NCDC, the prevention pillar was the weakest link. And I said, that's the only way, we must face that again, or else we'll be in trouble. Apart from prevention, you have early warning systems and surveillance. All these ones are based on data analysis. You track diseases with all sorts. Public students will know what surveillance is. There are many types. You do all that. And having seen it, you have to detect. And this is where your laboratory systems comes in. In this area, we're building a laboratory network, both nationally, zonally, and within states. And of course, having detected this, if you are not careful before the thing spreads, we must be ready. And the focus there is preparedness, response, and containment. But we should not wait for this disease to occur before we start getting ready. That's what happened to us in Ebola. That's what happened to us in COVID. We were not prepared at all. And that's why it took us quite a long time to respond. Mitigation and recoveries. And the last bit is partnerships. Collaboration, which is what we are doing here. We cannot effectively address emergency preparedness and response without collaboration and partnerships, because we don't have all the resources available. Now, this is one framework we are trying to advocate for innovation to address this resilience. Number one is multi-sectoral partnerships. We all know, everybody has spoken about it. It's very key. You need to involve everybody, including the private sector, the military, the economists, whatever. Integrated operations, everything needs to be integrated. Innovative financing, I think some of us are very key on this one. I mentioned NCD integration. Digital surveillance as key. This is just the framework. I'll just go into details again. There is nothing you can do in response, even in any government, without governance. And I think Olumide alluded to it. Governance, whether it's transnational, national, or subnational, we must do this, because without governance, there's chaos. And when you are responding to emergencies, there cannot be chaos. You have to do it in a way that you prevent chaos. What do you do? What do you look into? Coordination, policies, legislations, regulations, processes and procedures. These are many things here. At any level of government, these are things you need. If you don't address this, we will not make progress. They look very simple, but they're key. Then the next one is surveillance, like I said. We adopt all sorts of surveillance methods. Individual-based surveillance, event-based surveillance, environmental surveillance, and genomics. Nowadays, we are going to genomics surveillance, because then it's more of tech. You have to build capacity. And take, for instance, there's an ongoing COVID spread, whether we like it or not. People have been asking, what type of COVID do we have? Without genomics, you cannot decide that. And that's why Nigeria went into genomic surveillance. Build that capacity. Anything, innovative finance is key. Like Olumide said, health accounts in this country, we know it again. 75% over 75% of people, money we spend on health come out of pocket. The interest is that government is funding less than 30%. Under that funding, a lot of it is going to clinical health, curative care. Less than 10% goes to preventive care. That's how terrible it is. But again, we all know the state of the economy. So there is no way. We have to find a way of financing our systems innovatively. Now, One Health platform. In the context of emergencies of infectious diseases, like I said, a lot of diseases will come across as zoonotic diseases. Is it Ebola? Was it COVID? Lassa fever, yellow fever, dengue fever, all are zoonotic diseases, whether we like it or not. So to address it again, we've created the One Health platform. And those two key agencies, health, animal health, environment, and livestock, must come together in what we do in terms of governance, in terms of policies, in terms of systems, to actually address this. It can't be all. It can't be one. And of course, we need to innovate and build capacity in all this again. So people have talked about gender and equity. These are key issues here. Equity, for instance, we don't seem to appreciate it. what we have down south is different from what is available up north. In terms of resources, that a lot of differences. This is on collaboration and regional, there's what we call international health regulations, IHR, that every country in this world signed into. And it basically is that any country that signed into this must ensure that they build capacity to be able to detect, assess, notify, and report events immediately. We must respond promptly. And some people are even saying that we should adopt the 717. I said you must be able to detect an event going on within 7 days. How practical that is in this country, we all know because of challenges. And you must report within a day. That we see. And reporting again is mandatory. We report both globally and nationally. And this is what comes again in collaboration. A lot of these diseases have been detected at the private level, but the private sector people do not release some of these figures because they don't understand the issue of reportable diseases. And I'll give you an example. Recently, we detected some case of dengue fever in Edo State. And the state government sent out people. It took them quite a while, about 2 weeks before they detected it. But on final, when we sent people to Edo State, we realized that in the teaching hospital had detected there are since over 300 suspected cases of dengue fever. They They confirmed over 150. And they never reported to anybody until we talked to the CMD and we started talking to all the other people. And the question was, even in those states now, did you reach out to your neighboring states to let them know the issue of dengue fever? These are the problems we have here. And without collaboration, without all this again, we are all in bad shape. So that's why we are duty bound to join the IHR. Any new disease worldwide, they notify us. So if you detect any case of some of the notifiable diseases, you must report to them. And that's when they send you experts or people to assist you in case where you don't have those resources. Well, this is the same thing. In Nigeria here, we've created recently the National Action Plan for Health Security, Stage 2. That's a new one. Under that, again, it talks about cross-border policies, how we relate to our neighbors. Same thing with creating surveillance networks, and of course, digital divide, whatever it is. We are doing the same with the ECOWAS at the ECOWAS sub-region. We have the Regional Center for Surveillance and Disease Control, which we are part of. We're all working together. On a larger scale, the continent, again, there's the African CDC. These are levels of our collaboration at the continental level. This is the same thing here, so I'm not going to go over it. I've mentioned again, agreements, we must sign bilateral agreements, MOUs at the sub-level, and standard operating procedures under governance issues. These are things we do. Strengthening data and surveillance activities at all pillars, points of entries, facilities, laboratories. A lot of these are dependent on data collection. Disease occurrence, people's movements, laboratory results, etc. We put all of them together again, analyze, and look at trends. Without this, we cannot mount an effective response. So we need to train surveillance officers. They are key. There are very many. And of course, at the community, we create informants. We meet informants at the community. These are people who provide us ideas, information on data, disease occurrence, all types. They can describe them in different ways with the responsibility to fashion this out and get them out and analyze them. This is the digital tool framework we use at NCD, SOMAS. Interesting, when I got to NCDC, I had conflicting views on SOMAS. Some people said scrap SOMAS. Some people said you cannot scrap SOMAS because we're using this SOMAS. But we had serious challenges with SOMAS. But I'm glad I've not scratched SOMAS. But we tried to find out what was wrong with SOMAS. And part of it was due to we were using old versions, and they had elements of sabotage within NCDC, people who are so self-centered and try to create their own digital solutions. But we resolved the issue. But SOMAS is so key because we use it with WHO, etc. ECOWAS systems, again, they are working on SOMAS. A lot of countries are using SOMAS. So our SOMAS framework now is in a better shape, or we're trying to improve it. We're working with state governments, with SOMAS. We need to build capacity, digital services and local health facilities. SOMAS is good now, but it needs to get continuously upgraded to get it better. Under the One Health scheme, SOMAS again must be linked to the environmental information systems. We have to link it to our animal health systems, information systems. So everything must be interoperable. Yeah, for finance, like Olumide said, our funding for the health sector is small. So whether we like it or not, we have to look for other ways of financing this thing. Luckily, in NCDC, well, let me not say luckily, when I got to NCDC, over 70 to 80% of the funding from NCDC is from donor agencies, which is a mess, it's a disgrace. Very little amount of money comes from government. And the people, when COVID struck, COVID came in, a lot of money came into the country, and I think we went berserk. Apart from creating infrastructure, we didn't create a lot of systems. So they didn't know how to budget for this kind of thing. Since now you are pushing people to budget. So once they write something out, they are looking for one partner or the other to fund it. I said, that's rubbish. Me to looking words again now. I don't want to say luckily. You know, the water of funding from our partners, the US government, USAID, all sorts. So we are going to sit down again to rethink. Luckily, in this government, again, we are looking for different ways of funding these things. We are told the minister is all over the place trying to look for funding. We are getting support from the World Bank. But the support from the World Bank now is going towards building sub-national capabilities. Because you can sit there in NCDC, you cannot monitor the whole country. All the diseases occur in the communities, in the states. If you don't build local capacity to even detect, to collect data again, we're wasting our time, not to mount response. Right now, based on the donor agencies, again, we have called performance-based or pooled regional, these are things they are thinking of. Blended finance, the economists will tell you about this one again. Domestic allocation, we need to start fighting for increased budgeting from our legislators. This is what we were looking at it again. Well, digital surveillance, everything we are talking about has to be digitalized. We cannot afford it. That's the latest innovation here. Anyway, even from community health informants, points of entry, national surveillance, ECOWAS, African CDC, all these things again require real-time data analysis, dissemination, etc. These are the things again that help us to analyze what to do and guide us in our response systems. This is just a one health issue: environment, animal health, human health. They are interconnection. We cannot effectively mount an emergency response for infectious disease without a One Health platform. And then what do? We do joint training, create task forces that we send to various states, even across the borders with our partners. We have to map out risks. What we are doing now again at sub-national level, we need to go into all states again. Look at their vulnerabilities as states, not even country now. Map out the risks, and help them develop again action plans, just in case they have these emergencies. Without that, again, they can't mount to there. And of course, cross-sectoral teams, that's the One Health approach. Innovation, everybody has been talking about it. We have no choice but to innovate. No choice. And in doing that, we have to build capacity. I was, while sitting down again, looking at some of those, when Olumide was talking, he mentioned some things, like I said again, technology and innovation covers everything we do, whether from prevention, involving communication and information management, you need technology. Last week again, this guy, one Aproco doctor, came to my office. We were trying to discuss together. And he told us emphatically that the methods we used, like all these leaflets, handbills, all by this, are just obsolete. Nobody reads them. The kids don't read them, all those things, but we need to innovate. Look at what happens nowadays, podcasts, etc. He actually advised us. Surveillance, data analytics, AI. We need to look at detection. I've mentioned genomics. In the lab, we get a multiplex bead assay. This is another way, again, of trying to detect pathogens, multiplicity of pathogens all in one fell swoop. We need to consider, again, laboratory information management system. It's not technology-based. These are the only ways, again, that help us. In prepared response, you have medical countermeasures. We need to stockpile. We don't wait for emergency to occur. We look at seasonal calendars. We can look at one time or the other, we're expecting X, Y, Z. We start stockpiling things we need. Maybe drugs, maybe PPEs, maybe consumables, lab durables, etc. This is our stockpiling. But in stockpiling, again, we need things like logistics management, which some of us don't do, so we need to get people who understand logistics management, mobility, etc. So when it came to human resources, Olumide mentioned we tend to think very clinical. But in this world, we have people like epidemiologists that we use in NCDC, data analysts, other IT specialists, laboratory technologists, molecular biologists, geneticists. These are people we need here for emergency preparedness. Environmental animal health experts, environmental officers, veterinary officers. These are the people we work with under the One Health platform for us to actually work effectively. So without all this, so this where again, the issue of collaboration comes in. The same thing we are talking about here, these are the people here. Like I say, health security is everyone's business. The federal government cannot do it alone. We need to work with the states. We need to do it with partners, regions, line ministries, Ministry of Environment, Animal Health, Livestock. We need to all work together on this, including the private sector. What is our call to action? We should stop all this seasonal funding. It has to be continuous. How we do it is when we talk to our principals, talk to governors, talk to the members of government. We need to build permanent structures that are government-led with proper governance systems, again, to be able to address this. And what we do, there must be legal backing. Why I said the NCDC was created about, I think, 2008 or thereabouts. But the law backing NCDC came almost 8 years after. So for those 8 years, NCDC could not muster any money. But is this legal backing that confers you the authority to spend? Is legal backing that gives the appropriation how much you spend, how your structure will be, how many people you can recruit, etc. So we have to rely on law. These are things here again that need to be institutionalized. Somebody has said collaboration is necessary, shared vigilance, everybody, shared intelligence, and shared response. And of course, the message here is that borders should be bridges of shared protection, and protection is for all. Thank you very much.
Thank you so much, Dr. Jide Idris. I'd like to call on stage Dr. Ayo to please present to him the appreciating plaque.
Pick up the pieces.
Ladies and gentlemen, we move to the next session, which is going to be an interactive one, leadership session, talking about clinical excellence, staff engagement in emerging markets. I would like to call, so it's going to be a panel session, and I would like to call up the speakers who will be speaking to us. Please, as I call them, kindly appreciate them coming up to stage. So first is Samir Solanki. He's the managing partner, ECAP. And the next, Dr. Enataikos, MD, CEO, Get Medco. And then we have Brian Diva, CEO, AMC Hospital, Abuja. And the last speaker, Daniel Murphy, co-founder and senior managing partner, ECAP. And to moderate the event, the session, I would like to call on the boss himself, the leader, the group CEO, Evercare Hospital, Mr. Ifan Khan.
Pick up the pieces.
Thanks, Abiodun. Okay, welcome to all our panelists here. So today, we are going to be having quite a dynamic panel session here, and our theme is really empathy, excellence in emerging markets, and we want to capture this opportunity and learn from all our esteemed panelists here. And we're going to be showcasing also some of our staff. And so all the training that we've been doing, this panel discussion is not just going to be a discussion amongst us, but it is going to include people who have been through the training, people who have conducted the training. And so we're going to talk about all those themes in that context. And what we have is certain themes that we're going to pick on, and they're going to be, we're going to focus on empathy and leadership. We're going to focus on excellence and execution. We're going to focus on what's the emerging market advantage. We're going to have frontline integration. We're going to talk about innovation and how innovation and empathy come together, training, etc. So I'm also conscious that Dan needs to leave for the airport very soon. So we will start, with Dan, and to say that, as we set up our Evercare Academy and our training programs, and we've been doing this over the last 2 years now, how do you see that turning into more sort of innovative programs, and how have you seen that academy develop as you've seen the cohorts go through from all the way from clinicians to the front line?
Okay, thank you. Good morning, panel. Good morning, Lagos. Hope you're all well. That's a tough question to start. Thank you. What we've seen over the evolution of the training program so far is that, as has been recognised by the earlier speakers, there's good flow domestically into the system, and I think that's the bigger picture that we've taken with the work that we're undertaking with Evercare Group. Is across the respective markets, we're creating leaders that are moving back into the markets, which is helping principally the healthcare ecosystem. The other key differentiation is, what we've seen traditionally in emerging frontier markets is management development programs. Now that's not what we're focused on. We're looking at leadership development programs. Good leaders create followers. Great leaders create leaders. And that's been a lot of the initiative over the course of the last couple of years. When we then look at it, when we want to attract private and capital and FDI into these markets, we really do need tangible output, and the tangible output it has to be evidential. What is this creating, and what's the knock-on effect? And I'm really good at delegating, so I'm going to delegate part of this now. One of the things in particular that we've done, and an output of the workshop going into year 3, has been a product of working with the clinical cohort and working with the leadership team at Evercare on devising very relevant, very pertinent case studies, real case studies. Let's go and fix real world problems. Okay, let's not talk hypothetically about selling pens and evolution of plastic. Let's talk about what's going on in the medical industry that we can really try and fix. A byproduct of that has been an initiative, Peditails. Okay, and this is a pediatric patient engagement program led by Dr. Ayo and Dr. Assad in one of the leadership management workshops, where they're principally taking the leadership development initiatives, overlaying it with a case study to get to a service-based solution. Is there any way we can get a microphone? I'm stealing your thunder here, Dr. Assad, but if we could get a microphone at some point to Dr. Assad during the session. It's really important to note, and I'd really like him to get the recognition that he deserves for this, that this service that's been evolved by Evercare has now been recognized internationally, and Dr. Assad will be with some of the leadership group in Geneva at the IHF in over a week's time, receiving a gold standard award after this has won based on 350 plus nominations from 27 other markets. So congratulations, Dr. Assad. So do you want to tell a little bit more about the program before I butcher it?
Yeah, that's kind of like putting me in the limelight again, but thank you so much, appreciate it. But this could not have happened without the support. So Irfan and Dr. Ayo. So Peditails, I'll talk about very briefly. It's a pediatric storytelling initiative. So what we felt was that children who get really anxious in healthcare settings, are we doing anything for those kids to enhance their pediatric satisfaction or their satisfaction in healthcare settings? And if the kids are better, feeling better, then the parents are also happier and the staff gets more engaged. So very quickly, so we went about the storytelling-based approach, and it got picked up by IHF for the Innovation Hub. Very interestingly, with ECAP, with the training module or the LTP, the Leadership Training Program, we use that as a case study to demonstrate leadership training principles or leadership principles, let's say. So there's so many, and there's several individuals who've benefited from that case study through the training program that ECAP has put together. So that's very briefly, I mean, that's what I would like to talk about, what I wanted to say. And the stories have kind of scaled from Lahore to Lekki to Kenya. And there's several individuals over here in this hall who've been part of this journey. I hope that helped.
Thanks, Dr. Yeah. That's one of the things that I was also going to bring up is, can empathy itself be innovated? And I think that is a key project that almost demonstrates that, because it is storytelling and it is, an innovation in the world of sort of empathy. And so maybe we'll sort of continue that discussion, but maybe let me bring others on board. And Dr. Anna, conducts empathy training, and she has done this for our hospital here in Lagos. And so maybe just linking to that, as you can see that project has come through. It's sort of innovative. It's come through some of what we have been teaching, but it does bring the empathy question up. And how do you see that, linking to what you do? And then also, just as you answer that, I would ask Brian that in your hospital, you've just set up a brand new hospital in Abuja. What are the initiatives that you have started to take around, empathy? How do you think around that in a slightly different market? And it would be good to hear from you. But first, Dr. Anna, please.
Thank you so much for this opportunity. I want to say, first of all, that we started our discussions earlier this year with Evercare and GCO Elevate, which is our company. And something that was novel and so new in this society was the attention on empathy. Now, why is this important? Because research studies, whether you talk about Harvard research studies, MIT research studies, the BMJ journal in 2022, basically linked the excellent patient experience to decreased mortality, decreased hospital readmissions, increased adherence to medications and treatment plans, and so many other benefits. And so the Western world has started to pay attention to this because there was no empathy training that was institutionalized in professional schools like medical school or nursing school, and definitely not on this side of the world either. So there was an opportunity and a gap that was noticed, not just in Evercare, but this is nationwide. And I know we've talked about so many other issues today, legit issues such as infrastructure, public health, and funding and so on. But really there is a core human experience that is met at the end user, which is between the doctor and the patient, the nurse and the patient, the pharmacist and the patient, that is lacking in empathy. So I wanted to really commend Evercare for being at the tip of the spear in leading this transformational change and talking about empathy. And I really just want to recognize you for that. Thank you so much. Thank you. Our findings were actually quite staggering, and I want to share them with you. I don't know if I can get the... Thank you. Okay, thank you. So we did the Evercare training. Let me tell you how monumental this was, not just for the doctors and nurses, but also for the security guards, for the janitors, for the pharmacists, for every single one of the almost 750 staff at Evercare Lekki went through this training over 8 weeks in multiple role-based cohorts. And these were the results. So based on the surveys, about 134 people rated it a 5 out of 5, which is an excellent score. Many of them came up to me and said, is there any score more than 5? Because they found it so practical and so useful. And they kept asking, they said, please, can you take this to the government institutions, that lives will be saved because of this. And then, I'm sorry that this is quite small, but we had different parts of the modules and the training, and it showed, we talked about communication skills, collaboration, giving a wow experience, and a care framework, which talks about empathy. And many of them, they all stated, different aspects that they would want to focus on as a result of completing the training. What has been most interesting is that organizationally, there has been a documented significant improvement in the Net Promoter Score, meaning how willing are patients to refer this hospital to their family members and friends, and also a significant improvement in patient experience. Also, team morale, because of some of the workplace training and workplace habits and workplace culture training that we did. Process feedback, which basically ties into what's the seamlessness of the experience when a patient walks in and then walks out. And then end-of-life offerings, which was a huge part of our training because there's a significant gap in the level of compassion for family members who were losing their loved ones. And lastly, there was a decrease in patient complaints and escalations because we dealt a lot with de-escalation strategies and centering with care. And finally, medical errors, which includes identification errors, labeling errors, medication errors, shift transition errors, and so on. So I'm really, really glad about these results that we were able to effect that have shown even 6 months later in the performance at Evercare. Thank you.
Thank you. Thank you, Dr. Enam. Brian, please go ahead.
Thank you. Again, my name is Brian Deaver. I'm the CEO of the African Medical Center of Excellence, just commissioned in June. We are focused on cancer, hematology, and cardiovascular disease. So the question was about some of the things that we're doing to, I guess, inject or initiate empathy into our culture.
Yes.
Coming, as was just talked about, from the West, and having worked with over 100 hospitals, many of which are some of the world's top institutions, I've had the benefit of experiencing many hospital cultures. Some very, very good, some needing some work. Very good friend of mine named Britt Barrett, who was the CEO of Medical City in Dallas, he and I thought the same way and think the same way about management philosophy and working with teams and high-performing teams. He wrote a book, counterintuitive, called Patience Comes Second. And the premise behind the book is that if we hear our team members, if we acknowledge them, if we appreciate them, if we develop them and work alongside them, we won't have to worry about patient outcomes. Our doctors and nurses will feel valued, and they will do everything that they can to make sure that the patient and their families have a great experience. And so we've implemented that from the very beginning. I arrived 3 years ago when the hospital was just a hole in the ground. And as we have brought on new staff during the recruitment and interview processes, we made sure that those individuals were going to be a great fit for that particular culture.
Great, thank you. So let me bring in Samir here. We've talked about innovation. We've talked about empathy. We've seen certain results. We've seen how a new hospital in this market is, bringing that in. However, the talent scarcity that we have in emerging markets is a major problem. And so if we're talking about doing the right thing to our staff and our teams and teaching them empathy, we first need to have them and we need to retain them. And so let me bring in Samir here to talk a little bit about that, because we have been talking and discussing over the years around how do you bring talent into these countries. And traditionally what we have been doing is bringing talent from elsewhere into the countries, but we have now also started to see how developing local talent is possibly the way forward. But maybe let me ask Samir to speak more around that subject. And then also let me just say to all of you that as you see the appropriate opportunity to bring in the teams, please feel free to engage. So I love what Dan did is you've already started to engage the audience, and let's engage them as well, and feel free to bring them in when you think it's the right time. So Samir, please go ahead.
Thank you, Irfan. So just before we even entered leadership training, I've been a headhunter, delivering board advisory, executive search consulting services all across emerging markets, across the global south. And as we've discussed in our earlier interactions, these markets are challenging. They're not easy to find talent, and even within Nigeria itself, you just can't, relocate talent from abroad or even move talent within the existing healthcare systems here. Why? Because they are founder-led. Doctors have built successful businesses around their respective hospitals. You can't just poach their CEO, CFO, COO. That creates animosity in the market. And then when you look at bringing talent from abroad, they've now gone to the global north. They're compensated 3-4 times. And yet they want to make a difference in their home country, but at what price point? And it gets to a point when they do want to come back, you've got to look at all of these various costs, the red carpet service, they become prima donnas, and all of a sudden now the cost to company to bring an executive is 6 to 10 times the price point. And Brian, you would probably concur with me. Which is where we reached a point with Irfan and a number of our clients that this is not sustainable. And that's when we decided to build talent within. And that's when I had to change my mindset, which was pretty fixed. And Irfan challenged me to say, we've got to look at doing this differently. Let's build talent within. And that's when the Evercare training program was initiated. And the modules were very much customized for exactly what we're discussing: compassionate leadership, empathy. And Maria, who is there, you may have known by now. I think everyone knows Maria. Stand up, please, Maria. Maria is one of two of our master coaches, and she's supported us to deliver content around this space. Maria, do you want to come up or at least say a few words? Thank you.
Thank you very much, Irfan. Thank you very much, Samir, Dan, for giving me the opportunity to go a little bit and discuss about our academies. Yes, it was customized. We did assessments with the people, so we tried the topics to be aligned with the vision and the mission and the strategy of Evercare, and then what was the needs coming out of the participants. And it was a holistic approach. What I mean by that, we ran leadership programs, team coaching, that we are focusing on growth mindset. We did individuals executive coaching with everybody. The teams were working, going back to their markets on these growth mindset focus areas. And then at the end, we are running again the assessments. So we'll be able to see how was the journey, how we started, and what was the impact and what was the improvements. But I have to say one thing. I believe everything came from the engagement of the participants, of the vision of the company, and what we did is supporting them to go through the journey. So the success, I think, belongs to all participants and everybody at Evercare. Thank you very much for your engagement, for your empowerment, and for the improvements that you had within. Thank you.
Thank you, Maria. So we started off in 2024 with 14 participants, and that's the senior leadership team. We then selected a number of champions from that cohort. Those champions were involved in the delivery of the program for this year's agenda, which consisted of 50 leaders, 25 caregivers, 25 leaders, and I'd like to invite Uzair, Eric, and Tanya, if they can please come up.
Good morning, everyone.
So is there, when you think back to when you joined in 2024, what's one shift in how you lead or think about how's that shaped you today?
Okay, thank you, Samir, for giving me this opportunity, and welcome everyone in this Evercare Healthcare Conference. So, you see, what I understood was that leadership was always about answers, being very decisive, being very actionable, which is also right. But what I understood after the training was that it's more about awareness rather than answers. And when I say awareness, it also means that I need to, I found out what my gaps are. I found out what are the areas of improvement in myself so that I can create that psychological safety around my team that I am also the one that I don't know everything. So once you sit with the team and tell them, yes, we are having this discussion, and even I don't have all the answers, if it gives them confidence that, they can be comfortable, flexible, and then we can have a productive discussion. Another important thing is that after the training, I found out that as soon as you start proving yourself that you're the leader, that is where people start seeing you as one.
And now you've seen it on both sides. What surprised you the most?
I think the facilitation is a big challenge. Kudos to you, yourself, and Maria. I think the energy Maria has is absolutely amazing. I think we all cannot match Maria's energy sitting in this conference. But I think facilitation is something which is very difficult. You have to read the room, you have to manage the noise, you have to manage the silence. So, and also the attention to detail, because in that room, everything is revolving around you. If your energy goes down, everything goes down. So I think this is something which is very important for us, and a good takeaway back home for us as well. So thanks.
Thank you, Isaiah. And Tanya, you're going to be instrumental in shaping the Academy for 2026. What are visible changes that you noticed in your team? What decisions, And how have your teams, how have they been able to interact and make decisions since you started the program?
Thank you so much, Sameer. Thank you for giving me this opportunity to talk about this particular topic about leadership. When we first entered this program, we were a bit concerned about it. How will it go? What will we learn? How will we improve ourselves? But thanks to Maria and Sameer for their guidance and all that. But the most visible change is that now the leaders, as leaders, we are not just leading. We are actually influencing. We are changing the mindsets to the culture of open communication. Feedback, what we have learned from you guys is extremely important. So open communication, feedback, how to guide employees. It's more of coordinating with them, collaborating with them, rather than telling them what to do. So leadership is not about authority. In fact, it's about authenticity. It's about transparency and open communication. So this is the main change in the leadership, how we delegate rather than we lead the teams. So this is what we have. This is the main difference.
Thank you, Tanya. And Eric, you chose to come back and deliver the content and support us in 2024, 25. What motivated you to come back and support us?
It was the 360 that I observed, the ability to introspect and actually create leaders for the future. One of the things I noted the most, having interacted with Maria, was how do you reflect on everything that you think you knew? Do you know everything? Do you have an ability to learn? It was also very important to take note of the fact that we had the power to empower the next crop of leaders. And I do have a story that was very interesting. So our group CEO, Irfan Khan, knows that I like football and I live football. So when he gave me the opportunity to be the chief operating officer, he told me that you're now moving from a management position to a leadership position. Having done and gone to school, it sounded very simple, but it was not simple in many terms. So he gave the best analogy that I actually used going forward when I was relocated. And it was always, if you were playing football, it was easier when you're on the pitch than directing a team as a captain. But when you move from management to leadership, you move to the coach, to the sideline of the pitch. Now, you can see everything from a distance. You can see where everyone should be, but you cannot go in yourself and actually make the changes. You have to trust, you have to empower, you have to believe, and you also have to allow for mistakes because your team will learn from mistakes. So these were some of the opportunities that I noticed and I was able to do. And interestingly, one of the hospitals that, out of the 3 we have in Kenya, one of the hospitals, the manager's office is actually overlooking a field. So you can imagine how many times I used that analogy, and there were games going on, and I'd say, look at the coach. He's frustrated, he can't get in, but he trusts his team will figure it out and resolve. And at halftime, they will come, they will have a pep talk, and they will correct that as well. So this is one of the reasons I actually came back. Thank you.
Thank you, Eric. Thank you, Tanya, who's there. So these three are our champions
Thank you.
for 2026.
Yeah, absolutely. And I just want to say, I mean, thanks to these three, but this is what, you know, we are endeavoring to do, and I would encourage everyone here to think through, is when you develop talent from within the countries, it is sustainable, and then it moves forward. And then the others also see how there's a career progression and where they can go. And you can see that these three are a good example of that philosophy. So thank you, guys.
There is one more individual who is slightly taller than me. Maybe you can guess who this person is. He's a power forward and center, covering 4 and 5 positions. He has represented Beavers Basketball Club in Lagos, Showtime Hoopers in Oyo, and a 2-time member of the Oyo Nuga starting 5, where he was also captained for the Oyo Panthers. Any guesses who that may be? Please come up.
Thank you very much, Samir. Good afternoon, everyone. It's nice to be here.
Very good, thank you. And I just wanted to, you know, congratulate you on your performance and all the good work you're doing in your sport. How is that? Compare the difference and you give us your insight. You know, playing on the field, you know, in what you do and being part of this program.
Okay, so before the corporate world, and currently I still play. Like Samir said, I used to be the team captain, and as a captain, you have different duties to being a player. As a player, your duties is to be available when they call on you. Make sure you get those points. I don't know who plays basketball, watches basketball here. Get those rebounds and the likes. But as a captain, you have that responsibility to ensure everyone is synchronized. We all have different duties, right? And ensure we all have that goal in mind and that objective. And coming into the corporate world, I discovered we all have different strengths, different weaknesses. So it's up to you as a leader to ensure that everyone identifies their strengths. Although sometimes people do not know they have those strengths, but it's up to you as a leader to ensure they identify and they utilize those strengths. So those were some of the things that I saw on the basketball court that I was able to transfer to the 95 business world. Thank you.
Great, thank you.
Thank you very much, sir.
Thank you very much. Thanks. So let me come back to the panel now, and maybe we can, you know, start with Brian. I mean, you see how, you know, the effect of this training, you know, it can create that sort of momentum. And what I wanted your reflections on is, again, from a startup, a new hospital, as you said, you saw it as a hole in the ground, you've built it all the way up. Can you give us some examples of how you are seeing the emphasis on training related to innovation, related to empathy, and retention of staff, especially in the context of Nigeria, and what's your experience around that?
Yeah, thank you. We're still early, so the results are still coming in. That being said, we have spent so much time talking about these particular principles. We are now watching it in action. I have an expression that I use called carpet executives. And I have tried to make it clear to my team that we will not be spending our time on the carpet, which is where the offices are. We'll be out on the floor. And so you may see me out in the parking lot with the security. You may see me pulling weeds. You may see me with a hairnet, although I don't need one, in the kitchen prepping food. Or I may be emptying waste baskets and helping the cleaning crew turn over a room. Those are the things that we're looking for as our executives, our managers, our directors are working closely side by side with the team members, they begin to understand how important their roles are. If we're taking the time to be there with them, understand what their needs are, understand what their challenges are, then we can know better how to support them.
Right. No, that's great. I'll ask you maybe a slightly tricky question, but there has been quite a few of the Evercare staff that has joined your team.
I'm so sorry.
and there's 2 points that I wanted to bring up there. There's no need to be sorry, actually, because what we endeavored to do is to provide that talent. So earlier when we felt that our staff would move, we felt, okay, let's take this in our stride. And what we endeavored to do is create a pipeline of talent. So we are actually very happy that our team's members would move into different various hospitals. As long as they stay in Nigeria, we're happy.
Right.
And so what I wanted to ask you is that, because I know some of the team members who've joined you from us have been through this leadership training, do you see a difference in those people and others? Have you noticed anything?
I'm going to give you a specific example.
Sure.
Again, I apologize. We were fortunate to have had one particular team member from Evercare join us. She is our Director of Business Development. I think you know who she is, Kende.
Absolutely.
And during the interview process, we go through a pretty extensive process, very formal, and there's a long listing and short listing. She obviously shortlisted, and during the interviews, there was no question in my mind. She was up against 2 males for the same role, and she blew them away. Everything I was looking for in terms of her leadership, her curiosity, her dedication to what needed to happen, and her understanding of how to get there and how to build a high-performing team, I could tell that she had been well trained.
Excellent, excellent. And I think that's, it's really nice to hear that, and it's a validation, I think, of a lot of the work that we have been doing. And so, just to open up a question for all the panelists, whether it's innovation, whether it's recruitment, empathy, we work in markets that are urgent and target driven. How do you continuously ensure that you get the right talent, you can teach empathy, you can keep innovating? Because the challenges are quite vast. There's a lot of urgency. There's targets to be met, and then these things are sometimes sidelined. And so, what mechanisms would you say should be put in place to keep these front and center?
I can go first. I'll say that you have to make these changes a part of your culture. So, for example, Evercare has started Human Care X, which is basically their culture engine to help to transform not just patient experience, but also staff experience and bring back the humanity to care. So I think that there's no doubt in my mind that it isn't like, a side project. This is something that is now ingrained in the fabric and the culture of the organization. So with that, you are going to experience longitudinal results. You're going to find that over and over again, regardless of the turnover, people are going to start imbibing the culture of the organization. So we actually have 3 of the champions of the Human Care X here with us today. So I would like to welcome Chinyere, Bedan, and Danish to please come up. And they basically lead Human Care X for Evercare here in Lekki, Evercare in Kenya, and Evercare in Pakistan. welcome. Good to see you, Madam. Thank you. All right, so I'm going to start with Chinyere, who actually attended the training I referenced earlier in April and May. She is the head of her outpatient department here in Lekki, and she is so passionate about empathy and service culture. So I have this question for you. Which aspect of the Evercare Lekki training had the greatest impact on your department, and why, as regards to service culture and empathy?
Yeah, thank you, Dr. Ena. Thank you, everyone. Thank you, Ifan, for this opportunity. So first of all, I would say one of the things that was so exceptional about the training was the practicality of the training. We had a lot of scenarios that captured what we face in clinic. So I think the mystery shopping helped a lot. So it brought out what we as frontliners were seeing. So when the training came up and they could actually see themselves in it, and they could now see the right thing they should be doing, it's impacted on the team. Everyone had it pictorial. It was there. So when those scenarios played out in the clinics, everybody just remembered what Dr. Ena said we should do, and they just played it out. And we noticed that there was a decline in our issues. The escalation became something everyone could do, and not just the manager or the supervisors. The frontliners could de-escalate. They only mentioned it to the managers that they just de-escalated this. The impact was massive. I looked at the last data I compiled in the last 3 months, and we noticed that our patients had to give us feedback saying that the frontline team had the highest scores in terms of compliment over the other parts of the organization, which showed that that has gone into them and it's now working. So we expect that this will continue. It's not something we want to stop. It's something we want to continue, and it will spread around the whole of Evercare. Thank you very much.
Thank you. Thank you very much. The scenario she's talking about, we actually had live actors come into Evercare, and it was it was comedic, but it was also heavily tutorial as well, because people were able to act it out, and we were able to actually have these actors act as patients, and it was dramatic, but it drove home the point. Thank you so much. Okay, Danish, I have a question for you. We haven't yet done the training in Pakistan, but I know how passionate you are about team-based approaches and team-based empathy. And this was one of the things that we discussed during the Lekki training as well. It was actually interesting because the workplace culture module that we did was a last-minute addition for me. I just felt, if we're talking about this, we have to talk about the interconnectivity, the intercollegial, communications and things like that. But this was the one that got the highest amount of feedback. People kept saying, we need to talk about this more. This is a major issue for us. So I have this question for you. We spend a minimum of 8 hours a day with our colleagues at work. What impact do you think empathy has on workplace culture? And in your role, how do you address uncollegial interactions?
Thank you, Dr. Anna. I would say in healthcare, the empathy is something which is, I would say, is not very common, which we think is very common, but it's not, especially in our markets, emerging markets like Kenya, Nigeria, and Pakistan. And it's not easy to source the right talent. And to improve it in emerging markets, what we do is we take small initiatives like we have done in the partnership with E3 Hub. What we do is we have implemented a project which we call Empathian, which is basically humanizing ICUs. And we are trying to make it part of our routine of our on-ground employees, our healthcare staff, so that it becomes a habit. And also to handle uncollegial behaviors, what we do is we do quick and immediate discussions so that the compassion is not a project. We handle it not as a project, but we make it part of our routine life. Thank you.
Thank you. Thank you so much. All right. Lastly, Badan, you are one of the leads in Kenya. And I wanted to ask this question. Trust is eroded much faster than it's built. In your role, and please share what that role is, how do you help others rebuild patient trust after a mishap, whether it's directly or indirectly related to a staff member?
Okay, thank you, Dr. Ina. Thank you, Irfan, and the rest of the panelists. My name is Bidan Gadua, Relationship Executive and the Client Experience Manager at Avenue Hospital, Thika. So trust is like a glass in healthcare. Once broken, it takes some form of cattle. You need to look at it quite keenly so that you can be able to rebuild it. So the first aspect would basically be honest listening. We need to basically listen to both sides of the story, both from the patient and also from the staff, to basically get to know what happened. Because basically what I've been able to identify in my work is that patients cater to more than, sincerity is more important to patients than actually perfection. So first of all, basically listening to basically what happened. The second action would be now taking action. What is the way forward? Can we be able to fix what went wrong? Can we be able to also communicate the change that we've been able to impact to both the patient and also to the staff member? So this is about reconnecting. Reconnecting is a bit important because this is how we are able to bridge the gap. Is it that call to that patient? Is it that bedside conversation to that oncology patient? Is it actually just that card to that pediatric client over the pediatric ward? When we're able to bridge this gap, we're able to redefine trust. This is how we are able to even get a client being your own marketer. This is about how you're able to build trust with the staff. And when a staff trusts this particular process, this trust is able to go back to actually the patient. And actually, finally, is how we are able to now build the culture over to staff. At Avenue Hospital, Thika, we do have patient experience committee meetings whereby we are able to sit down with the heads of department. We are able to review all this raw feedback, basically get to know this is what the patient said, this is what we are able to do, and this is actually the way forward. When it goes back to the patient, as I've been able to say, it's that call-in. What I do believe, trust is very, very sincere in this activity that we do. Thank you.
Thank you very much. Thank you. So we've heard from three amazing empathy warriors, I would say. And my recommendation to anyone who's a leader of a hospital or who's the leader of any healthcare organization is this is such a human profession, much more than any other sector in the world. So it's really important that you invest in the innovation and inculcation of empathy within organizations. And you can do that by bringing outsiders like myself and like ECAP, but more importantly, by creating champions within your organization who have been trained, and they can help to spread this behavior and this culture of empathy within the organization so that every patient and every staff, every colleague, every leader has an excellent experience. Thank you so much.
Thank you. Okay, so thank you, Dr. Anna, for that. And it's again amazing to showcase the talent that is emerging from the different courses and things that we do. Maybe a question all the way through. We talked about innovation. We started about innovation. How do you define innovation in emerging markets? Is it technology? Is it process? Or is it mindset? What do you think? And I'll start with Dan.
Ooh, right, okay. In emerging markets, I think it starts with mindset and is quickly followed by fixing problems. What we see in developed markets at the moment is too many institutions, too much private capital being thrown at building digital banks that aren't needed. Whereas you see real success in agendas in emerging and frontier markets where they can provide banking facilities to the underbanked or the unbankable. So I think it's starting with the mindset. Dr. Okanola mentioned during his presentation, he mentioned the Thailand example. Yeah. And he mentioned changing the perspective of talking about healthcare as social service to looking at it as a factor, as contribution to GDP. And I think that's absolutely critical. Right. And that's changing the mindset from the top down to then filter into the ecosystem. And then you'll get these spin-offs in what Evercare are leading with E3, these spin-offs of innovation, because you're creating the environment to do so. You'll get healthcare professionals interacting with technology professionals. You'll get, again, to Dr. Idris's slide on the evolution. You know, human capital feeds into financial capital, and you'll start to get more varied manners in which ventures can be financed in emerging and frontier markets. Once you can give the investor community confidence, there is depth in the talent infrastructure.
Great. Great. Yes, please, Brian.
Thank you. If I look at the Latin root of the word, innovation, nova, it just means new, introducing new. And so you can take a very developed market, let's just say like Europe or the US, with very sophisticated, very complex systems, and yet introducing or reminding people of fundamentals, that may be innovation. And so really innovation is just introducing, and you mentioned technology, mindset, process, it's all of the above. But bringing something new to the process that, or to the working environment that changes behaviors, changes the results in a positive way. It could be something very simple, something very fundamental and very basic.
Great. Thank you. Thank you, Brian. Dr. Enna, please.
I'll take it from a different approach. Definitely innovation is a mindset, and a mindset that has to flow from the top to the bottom, because you do have to encourage it and foster it. The other thing that I would say about innovation, and I'll take this from my own experience, is that you have to create space for innovation, space and time. Now, in my prior role, I was chief of medicine at Kaiser Permanente in the DC, over the DC and Maryland area in the US. And as in that role, we became the most innovative department because that was core to my identity. I thrive in innovative spaces. So I would actually create innovation times for my team to actually have the space outside of clinical work to begin to think of ideas. So we would throw problems out there, and then we'll just start bringing out solutions. And having the support of financial leadership and things like that was very helpful. Beyond my leadership team, we also created space within the frontline physicians to procure and prefer ideas. And we took each idea seriously. We gave them feedback like, oh, okay, well, this idea, we're going to do this, and we're already on phase 1, or this one, we're going to table it for later. But they appreciated the feedback. So I think that to build an innovative culture, you do have to have, it starts with the mindset of the organization, of the leadership, and then that leadership has to actually encourage it by creating space for it and time for it, so that, because people aren't really thinking innovation when they're knee-deep in clinical work. So letting everybody know we're having an innovation meeting, everybody bring ideas, these are the problems we're going to be solving. It does create, it allows for innovation to grow and thrive.
Okay, thank you. Samir, any comments on that, and then I can move to the next.
Yeah. If I think of innovation, I'm going to use the Evercare Academy as a prime example, because what underpins the training program is the tools that we have applied, and these tools are state of the art. And I think Dan spent a year studying 150 different technologies, different assessment tools, and we've narrowed that down to 2 tools. One is the discovery process, which assesses EQ values and behaviors, but more importantly, the second one, which is the mindset advantage, and that's based on Carol Dweck's research from Stanford University, and that assesses fixed versus growth mindset. So the innovation that we've implemented in the academy is taking data sets from a traditional 360, from the discovery process, the mindset advantage, and then integrating that data to give you ultimately your DNA, okay. And from that, we've been able to really work closely with our individuals on their development programs.
Okay, thank you, everyone. So I think, innovation, I think mindset really stands out, from a process perspective where we need to kind of drive that through the mindset. Now, what we have seen is, some of the frontline staff coming through, some of the management coming through. One of the I think innovations or successes that we have seen, I would also like to showcase the clinical talent, and I would like to invite up Dr. Tahir Yunus and Dr. Arinze. And as they come up, I'll tell you, these are two doctors, very senior doctors, who have, across Pakistan and Nigeria, worked together, and what we have set up is a clinical training, which we tested out, where one surgeon from one country comes into the other country and teaches and trains the other surgeon. And this was a sort of a pioneering setup, and it's worked beautifully well. And so what I want to demonstrate is how we have penetrated throughout the organization. And that is the power of the Evercare Academy, the innovation that we are bringing together, the empathy. And I think in those two people there, you see all those things together, and it's at that clinical level. So I'd like you to just give a sense of how did you feel when you were being trained and when you were training, and what what are those other things that you you got from this? Because one is the training, and this is bariatric surgery. So Dr. Arinze is now a bariatric surgeon. He's now doing his own surgeries. He's soon going to do a fellowship, etc. But what I would like to hear more about is what is the innovation that you saw there, and how did you feel when you were being trained and you were training?
Well, thank you very much for this opportunity, first of all. And I must say that it was about a couple of years ago when you brought up the idea and the concept, and I must say it was something that never struck to me. I mean, traveling across the globe and teaching somebody or creating a service that was not present and starting from scratch. So I must say that there was a fair amount of hesitancy on my behalf, but I was open to the idea, and I said, well, let's try it out. So then when I arrived here, again, the new culture, the setting, the environment, but the best thing about it all is that when I came here, there was this warm reception, a welcoming attitude. Everybody was, come on in, let's be part of this, let's work together. And the whole team here got together and we started working on it. And Arinze, tell me what happened then after that.
So just like you said, there were some trepidations in everybody's path. This hasn't been done before. We didn't know what to expect. But I must give it to Dr. Tahir. He was very receptive, very friendly. And there was this jovial and convivial environment. The team got to work immediately. And we didn't have to invent the wheel, sort of. So it was more of a plug and play. He brought all the policies and guidelines that has been established in Lahore that was working for them over the past years. And through virtual communication and physical presence, we're able to develop our own policies and pathways and guidelines. And we kicked it up immediately. I would like him to make a few comments about the first couple months of service.
Yeah, so first of all, we opened up all these instrument sets. We sort of set up these instrument sets. We started working with the on-ground team, the dietitian team, the nursing team, the operating room staff, the anesthesia team. We set up our anesthesiologist, Dr. Atikur Rahman, came. He also participated in setting up the whole recovery unit, the anesthesia protocols, without which nothing could have been done, actually. Dr. Howard was here. He participated in setting up the ICUs and how the recovery unit would be for these patients. So I think it was really a team effort on everybody's behalf, and we were able to start conducting these surgeries and see the results. And how many have we done till now?
So if I'm, for Lekki proper, we've done about 20 bariatric procedures. We also had the opportunity to visit Lahore on 2 occasions and participated in surgeries there. So in total, we've done about 35 to 40 within the 2 platforms over the past 18 months. And it's interesting to state that we've not had even a single major complication. The last cohorts were done between Friday and Saturday last week, and all have been discharged home in perfect health.
Yeah, I must say, we just did like 7 cases on this trip while just before the conference. I mean, we did 7 cases the last 3 days. It was wonderful. And each time around, we've had a flavor of the culture. We've had experiences. Arinze has taken me to some nice places, and we've sailed around this whole area in a speedboat, enjoyed the waves, taken pictures along the way, and experienced the food and the culture and the nice. What was your experience?
And that, I was just going to bring that up because what I have seen beyond the clinical training is the friendship that has developed. And I know you've both got to know each other's families. You've been to each other's homes. You've had family gatherings and get-togethers, which has been absolutely amazing to see that. So it's
yes,
great.
Yes, Ifan, and that's the beauty of this platform and the convivial environment that this collaboration has been able to generate. And it also has doused a lot of misgivings that people may have working with others from different cultures. And when you get to know people on a personal basis, it transcends beyond any any idiosyncrasy, so to speak, or a suspicion that you may have. So it's been wonderful, and every time it seems as if a friend is coming back home to Lekki whenever Dr. Tahir comes, and he always looks forward to me coming to Lahore. I mean, the last time we spent, how many hours? Almost 6 hours in his house with his family and with his dad, who coincidentally has been to Africa, many countries in Africa, and we're able to share ideas where the Zambezi River is, routes from South Africa to Tanzania and all that. So, and it has also transcended down to the team. I mean, we've had people from Lahore, theater staff, nursing, and other general surgeons visit Lekki, and it was almost as if they've been here all their life. So I think that's the beauty of this collaboration, and we want to look forward to more collaborations in the future.
Absolutely.
And so I think it's the real spirit of connected care, transcending healthcare.
Exactly.
Across borders.
Yes.
Thank you very much.
Thank you. Thank you very much. Thank you, Dr. Tahir. Thank you, Dr. Rinze. Thank you. And I think those are 2 doctors who you see, surgeons who, can easily go to the UK or the US. They are well trained. They can leave their countries. But I think this process and what we have started to do for them is a retention strategy as well. Keeps them, going. And like they said, it's not just them, it's the teams that have gone through. And so all the people that you've seen come up today have had the similar experiences, through that. So I think that's where now you can see innovation, you can see excellence, you can see empathy. And it all comes together. And so what, we'll come to closing, and I'm conscious that Dan and actually Dr. Tahir are on the same flight that is leaving at 5 p.m. today, so we need to get them to the airport. But let me just close and ask you just to go through one. To sort of finish this sentence as a closing for everyone. Leadership in healthcare today means, complete that sentence.
Leadership in healthcare today means change.
Okay, good, thank you. Brian, please go ahead. Leadership in healthcare today means what for you?
Thank you. It means being one with your team and truly understanding them, what their needs are, and how we as leaders can best support them and model what it is that we expect. Yeah.
Okay, thank you. Dr. Anna, please.
For me, leadership means seeing yourself in your team and bringing out the best in them. So a blend of empathy, innovation, and driving the team to excellence.
Thank you. Samir.
For me, I think it's discipline, mindset, and the ability to lift others up.
Okay. Excellent. So, I want to thank you, all the panelists, for all your insights. I want to thank all our team members who came up and spoke. I think, what this demonstrates is that emerging markets, we are not waiting to catch up. We are actually designing, the new model of healthcare. And I think what we have seen and demonstrated across this panel, the discussion we've had, the people we've seen, is something that I'm very proud of, because we are not just talking. We have actually walked the talk. We have actually shown results. And I would invite, people like Brian and other institutions who are here to work with us. And that is what I call the emerging markets exchange, the health exchange. How can we work together, and how can we make this scale? Because we can do this individually, we can see a few teams doing this, but then it is about scaling this now and beyond the borders of this country to the other countries, our 3 countries, but even beyond those countries. And how do we invite more and more people into this? So what I would like us to closing thoughts from me are to say that let's all really come together, work together, bring other partners to the table, sign the board at the back there and say, let's be on this and let's work together. So once again, thank you to the panelists. Thank you so much for your inputs. Thank you, everyone. If we can open up for some questions. If there is any questions in the audience, we can take 2-3 minutes if there is any questions from the audience, and then we'll move to the next session. So I see a hand up there. If we can get a mic.
Good morning. My name is Ayomikun Kekereko. I'm a 200 level medical student at the University of Lagos. I really must say I am very enlightened at this conference. My question is, what Evercare is trying to do with the training, can something like that be brought down to the students' level? Because yes, it's true when you get to a lot of primary healthcare institutions like Luther and some other hospitals, not a lot, but a good number of people are not really inclined to such empathy training, and I feel like it's not as versed in Nigeria as it should. And from the research and from the impact that I heard it has been happening, I feel like starting from the foundation, the grassroots, which are the medical students like us, it makes the building stronger because the foundation has been strengthened. So is there any plans for stuff like this to move to the student level? Thank you.
Thank you. For sure, I think what we've been talking about is how do we scale this, and part of the scaling is to then implement and get this access across to universities, and that's one of the reasons why we have students as a major part of our conference, and we have facilitated them to be here. So, we will, as part of our Evercare Academy, bring this to that level, and I fully agree with you that that is the foundation and that is where it should begin, and then we'll have a brighter future. So thank you for that question. Okay, we'll take one more there and then we can close. Thank you.
Thank you very much. Good afternoon, everyone. My name is Dr. Olubukola Olawuyi. I'm the provost of the College of Nursing, Lagos University Teaching Hospital, Idiaraba. I want to say that I'm also looking forward to a time that we even begin to export our experts outside this country. How do I mean? we had a collaboration with Evercare Hospital this year. And I want to tell you that our students, they were greatly influenced and they learned a lot. So to collaborate what the medical student has just said, please can you help me to applaud Evercare Hospital? Initially we had just the neonatal nurses and the pediatric nurses to come for clinical experience and exposure. But on returning back, and other people like the critical care, the perioperative nursing, the accident and emergency, all of them were eager to come down to this place to learn. I want to tell you they learn. And they have more confidence to go out there to practice nursing very well. So I want to say a very big thank you to you at this moment. And I want this collaboration. It's a pity that the CMD had gone. I'd recommended that this collaboration should continue. And I believe that the management of Evercare Hospital, you are ready to accept us. We gain a lot and we want it to continue like an Oliver Twist. Thank you so much.
Thank you. Thank you very much for your kind words. And with that, let me close this session. And once again, thank you to the panelists. Thank you very much.
Pictures, please, the plaque presentations. So we're going to have, if I can present to them. So we have Daniel Murphy. Brian Diva. Dr. Enataikos, MD. And Samir Solanki. Okay. Then I'll have Saba present to our boss.
To our wonderful moderator, Irfan Khan.
So group pictures, just everyone. So we also like to join the leaders. Pictures, please. Saba. Thank you so much. Thanks, Ifan. Thanks, speakers. And I can say I was also part of the trainings from Dr. Enna, also the ACAP, and I can say they are not just instructive, but very practical sessions we had. Something our staff are willing to have every year. We got feedbacks in HR that these trainings are delivering immediate impact. Yeah, and thank you so much. Thanks again. All right, we'll proceed to the next event. But before we proceed, Saba, someone sent me a text while we were sitting that they like your robe. And they like to get it. So do you want to tell us the inspiration behind this?
Thank you, Abiodun. So I'm here representing and advocating Evercare's ethos of culture and diversity. This is a traditional sari that's worn in parts of Pakistan.
Thank you. Thank you.
So for our next session, may I invite onto the stage Dr. Ifi, who is the CEO of Abuja Clinics.
Yeah, the CEO, EHA Clinics. Welcome to stage.
Okay. Good afternoon, everybody. Let me start by apologizing for my voice. You know, a few months ago, I said it was my kids who brought colds home. According to ChatGPT, it's lasted about 2 months. So if you're an ENT in the room, I'll see you first thing Wednesday. I have the distinct honor, somehow misfortune, of following Irfan Khan, the charismatic, empathetic leader of the Evercare group. Can we put our hands together for him? It's really been a thought-provoking 2 days. I think I have the easiest job in the room because I'm just moderating this panel. So I'll be inviting 6 of Evercare's best and brightest, who are really the most intelligent people here, and will be taking this conversation forward. So what are we going to be talking about today? Patient safety and staff engagement. Now, everybody here in every hospital talks about safety, but achieving it depends on how engaged our people are. Today, our 6 distinguished panelists represent 3 countries, Nigeria, Kenya, and Pakistan, and they bring perspectives from operations, clinical leadership, quality, and nursing. And over the next few minutes, we'll explore how engagement, leadership, and systems thinking drive patient safety, not just as a policy, but as a lived daily culture. So please help me welcome my panelists. The Chief Operating Officer, Evercare Hospital Lekki, Peter Osuji. Please put your hands together for them as they come. Consultant Urologist and CMAC, Evercare Hospital Lekki, Dr. Ifedayo Adejare. The Chief Quality and Nursing Officer, Evercare Group Nairobi, Penina Kiria. The Chief Operating Officer, Evercare Hospital Lahore, Uzair Shaikh. The Chief Operating Officer, Avenue Group, Eric Ocheng. And last but definitely not least, the Head of Quality, Evercare Hospital Lahore, Sadia Pervez. Please put your hands together for my wonderful panelists as they all come up. All right, shall we begin? Thank you so much for being here and coming to talk about this really interesting topic. So we'll start with, an icebreaker. And I'd like to start with Sadia, because she's looking so beautiful and sitting right next to me. In one sentence, what does patient safety through staff engagement mean to you?
Okay, so good afternoon, everyone, and thank you so much for having me on the stage and to discuss about this important topic. So for me, in one sentence, what does patient safety and staff engagement mean is to build a culture where all the team members are empowered to raise their voices, to raise their concern, and to take ownership of patient safety.
Thank you so much, Sadia. Peter, do you want to go next?
Yes, to me, patient safety means treating every patient that visits the hospital as if he or she is your son, your daughter, your mother, your father, your wife, or your husband.
Awesome. And indeed yourself, right? Yeah. Because I think every healthcare manager should also be an expert patient, because it could be you. We're all patients. Or we'll all be patients one day. Penina, what do you think, in one sentence, what does patient safety mean through staff engagement mean to you?
For me, patient safety means doing the right thing on the right patient at the right time.
Awesome. Brief and impactful. Eric, do you want to go next?
Thank
Hello. Good. For me, it's safety to speak. And when you speak, it is valued, it is appreciated, it is listened to. But also patient safety means being empowered to act, having accountability and ownership, and the power to actually change.
Yeah, there's nothing more frustrating than speaking and then nothing happens and not given the power to act. Very, very interesting point. Dr. Adejare?
For me, patient safety, from my perspective, it's to ensure that nobody goes home with a condition they did not come to the hospital with, whilst ensuring that staff are able to speak up and point out issues that arise when they arise.
Awesome. Thank you so much. And finally, Uzair?
Thank you, Dr. Fee. So, in one sentence, I think working in hospitals, patient safety should be a way of life. Thanks.
Thank you so much. Peter, let's go to you first, right? You're head of operations, and a lot of the times the conversation is about how to ensure sustainability, how to make things work. And in some contexts, the first things that suffer is patient safety. So how do you operational decisions like staffing, workload, or infrastructure directly affect patient safety outcomes?
Thank you. Because people are the greatest assets, no matter what you have to, it's a balancing act. And it has to be done in such a way that the staff that will take care of these patients, the job is apportioned in such a way that it's not overwhelming. It has to be, the staff will have to be prepared to be emotionally stable in such a way that the staff will be interiorly recollected, interiorly ordered, and psychologically happy to render his or her job. Because if you take care of your staff very well, they will sincerely take care of the patient, and that is where safety starts.
Awesome. And I know it can be really difficult because if you notice, a lot of the times when there's a safety issue, when you do a root cause analysis, it's always the temptation is we don't have enough staff and to throw people at the problem. So really that can be a difficult balancing act, that to establish a root cause that doesn't necessarily add another layer, but actually adds empathy and adds safety without necessarily increasing number of staff. Thank you so much for that, Peter. So I'm just going to go straight to you, Dr. Adejare. And you manage a lot of doctors. And, everybody knows, everybody has talked today about what the doctor-patient ratio is. It's atrocious. One doctor to 5,000 patients, which makes it a really high-pressure job because you have to get through a lot of patients. So in those kind of pressure situations, sometimes quality suffers. Now, from a clinical leader's perspective, how do you foster a safety culture among doctors who consistently work under pressure?
Thank you, Ify. I think the first point is to be empathetic to the people that you work with. That's not very difficult if you are also involved directly. Maybe a bit more difficult if you're coming in and looking in from outside, but that empathy is key to understanding the challenges that people face on a day-to-day basis. The second point would be to ensure, to look at it from a standpoint of you're working together as a team, to encourage people not to work in silos, to encourage your team members to share ideas, solutions to problems, to bring these up so you can quickly solve them. And that brings the point to incident reporting platforms that you may have in your institution, training people to use it, because for the vast majority of Nigerian clinicians, we were not trained from the get-go to report incidents. So it's not something that comes as second nature. We more would complain about things that happen, but to report it and bring it to notice so that solutions can be brought to bear, that's not it. So training is very key, and as I mentioned, working as a team and not in silos. This kind of approaches help to help prevent problems and make you achieve what goals the organization has set with regards to patient safety. And also it helps with staff engagement as well.
Thank you so much, Dr. Dejari. And one of the things that has really impressed me about Evercare and a lot of what I've heard at this conference is a lot of the times in discussions about empathy and customer satisfaction, we forget to talk about the healthcare workers, the people who have to provide this care every day. And as much as it's great to put the focus on the customer, one of the things that Evercare has done that is so impressive is to put the focus on the healthcare worker, on caring about them, on being empathetic, on prioritizing their needs, because Oprah says this thing, hurt people, but care for people also care for others. So I think it's a good place to put your hands together for yourselves. You guys are doing an amazing job. So, Penina, and a lot of people should know this, but nurses are the engine room of many hospitals. Without you, we would be lost. And you are the backbone of patient safety. Now, how do you keep your nurses engaged, especially when resources are stretched? And that is the theme across Kenya, Nigeria, Lahore, and the rest of the world. How do you keep them engaged?
Thank you for that question. And I really want to appreciate the fact that it is very well known that the nurses are the backbone of any healthcare system.
Yep.
However, I am not so sure that the initiative that has been begun at Evercare has really kicked off out there. I think the slogan of this conference when we were starting up was actually fired up. Those who were there, fired up.
Ready to go.
Ready to go.
Fired up.
Yes, that was the slogan. And I think it's a statement that we are making today with the launching of Evercare College and Evercare Training Institute, where we are telling the world that we are the first to think that healthcare workers really need this training. You realize that in most of the colleges, medical colleges, universities, these are things that are not taught there. So when we graduate students and they are coming to work for us in whatever, whether it is government or private, you're finding that they find it very difficult. I was only taught to give medicine to patients. I was only taught to tell them that your patient is dead. And that is exactly what is going on. So what are we doing to keep the nurses engaged? A lot of training, discussion happened this morning, and I think that is where we need to be focusing on. And one thing that I'll tell you is that also what we've realized is that we have been working in silos a lot, as my colleague here mentioned. So how do we bring the nurses to be able to speak the language of the doctors, to be able to speak the language of the physiotherapists, and that shared collaboration is what we are looking for. That is number one. Number two, it is how do we speak, how do we disseminate information? It is about feedback. How do we give feedback to our teams? Are we communicating exactly what happens, at the strategy level? Do they know even exactly what we are looking to achieve as Evercare? So that is what I'll be looking at. You know, sharing data real time, telling people that this is how you're performing. That is the second point that I want to bring forth. But the next thing that I'll be talking about is celebrating small wins. You know, it always keeps them motivated when you keep telling them, well done. You realize that nurses spend, I'll say, more than 90% of their time at work. So can you imagine that person who spends that time at work, if they are not appreciated, what happens? So the patient in the long run is the one who pays the price. So I'll leave it at that so that I don't take a lot of time, but there's really so much that we do to engage staff.
And just as a segue to what you said, I think we should say to all the nurses in the room right now, well done. I think we should put our hands together for them. And you bring up a very important point about whether our curriculums at schools are built in the past, right? Static. I was having an interesting conversation next to me, and we're comparing notes about medical school in the UK and medical school in West Africa. And, you know, she was saying, oh, she got communication skills training. And we're like, no, I mean, we got disease training. You know, at the end of the day, are we training medical, clinical staff for the future of the new patient, the patient who is going to check ChatGPT before coming to you? Thank you so much. So, Eric, let's talk a little about staff engagement. Seems like a buzzword, feels a little abstract. What does it really mean? But how can we measure it? What metrics, what signals tell you that it's working, that it's actually translating into safer care?
So staff engagement, first and foremost, should move from it being a task. We all have the strategies, excuse me, we all have the strategies that we've set out. We want to go for JCIA, we want to go for COSASA, or we're a now patient safety facility. However, the way we measure engagement is actually seeing the voluntary willingness of your staff coming in to the different committees and to the different programs, and actually being able to provide solutions to challenges that they're facing, or how we can actually enhance the programs. So, you know, away from clinical engagements, you can also find how we measure from our patient satisfaction, right? This is a very good way to see how your staff are engaged. We've all spoken about how we will take care of the staff. Now, we need to see if they're taking care of our patients. So the staff engagement is a very good way. You saw Dr. Enna talk about the NPS and the patient satisfaction index that we see as well. It's also the collaboration between departments.
Awesome.
Now, quality cannot be achieved in a silo. So how well is the multidisciplinary teams you have in your organization? How well are they collaborating across the departments, across the building, in order for them to be able to achieve a common goal? So these are some of the ways that you can actually measure and look at how best your engagement is working within your facility as well. There's also the reporting, right? As you've heard from Dr. Adejari, when they went to school, incident reporting was not something that they were taught, right? Now we have to look at incident reporting. Someone looking outside from inside into healthcare would say, these guys are reporting too many incidences. But from an internal perspective, from a quality perspective, we are happy to see these incidents being reported. Because the higher the incidents, that means there's a culture of safety, we are comfortable reporting, and we're looking to do something about it to ensure that it doesn't happen again.
Exactly.
Escalation. How many times do you find that someone did not escalate in order for them to get assistance or to make the right decision? They did not collaborate with a physician, the physiotherapy department, or the nursing team in order for them to make the best decision for the care for the patient. So there's quite a few things that you can look at in terms of how engagement can be measured within a healthcare facility.
Thank you so much. And you bring up a very important thing about incident reporting. And it is a direct reflection of the culture of safety. And, you know, yesterday during our panel, I said something. Whatever you decide to reward, incentivize, recognize is what people will do. So last year, we had to add incident reporting targets to our OKRs. What that means is that we demystified it, which meant we encouraged it. Of course, we got some funny reports, but we made everything important. Because now, managers are chasing people and saying, please report incidents. When we demystified it, when we made it part of what we recognize and rewarded, then you can kind of codify as part of what the organization, finds important. But like everybody has said, it's not something, when you even use the word report, it's like, ooh, what, am I reporting my senior? Are there going to be repercussions, things like that? So very interesting points you've raised about using incident reporting as a gauge for staff engagement. So Uzair, let's go to you. In Pakistan, and well, everywhere around the world really, workforce shortages and burnout are real challenges. How do you maintain morale while ensuring high quality and safe care?
So, Dr. Effie, you are absolutely right. This is a big issue, and as you rightly said, not only in Pakistan, but all across the globe. But what I would say is that the challenge for us is not only shortage and burnout. The challenge is way before that. That's the availability of talent, the availability of HR. So once you find the right HR, you attract the right HR, then the shortages and the burnouts that come following. So for us, as soon as we find the right HR, the right talent with the right skills, with the right communication skills, absolutely necessary. So for us, the challenge is to keep them engaged. So we do keep them engaged, and with all the Gen Zs are now coming into the organizations. And I think yesterday's panel session, it was discussed. I think Jay mentioned that they want to be the CEO in 2 days. So I think these are the challenges that we are also facing. But what we are doing is that the leadership is now more visible on the ground. We are communicating with them proactively. We are engaging them proactively. We are working closely with them. For example, if there's any shortage or burnout in the session, I would like to mention one example. And as I said, that leadership visibility is very important. We had a situation in ICU in which we had shortage of staff. The occupancy was very high. And as soon as our CNO, who's sitting right here, found out, she went to the bedside. So she did an 8-hour shift bedside in the ICU. So that is something that the staff also says, that these guys are not giving us instructions. They are coming on the ground and helping us by taking actions for improved patient safety. So, yeah.
Awesome. Leadership is no longer in the Gilded Tower. I loved Brian's examples, whether that is helping people take the trash out, wearing a net and going into the kitchen. That is the leadership that our people need and our people respect. So for every leader in the room who puts their hand to the plow, gets involved in the work, well done. You can put your hands together for yourselves. And let's talk a little about data. Data is another buzzword. Everybody's talking about data, the availability, non-availability, presence, absence. But what does that really mean to our frontline staff? And Sadia, how do you make quality and safety data more meaningful to the staff who are at the front line dealing with patients on a day-to-day basis?
Thanks, Dr. Iffy. I'm glad you brought this up. So, again, we'll talk about communication, right? So when we talk about communication, we just not need to let the data come in and, make some fancy reports for the board or for whoever we want to, but we also need to communicate that data to the staff on the ground who is working, day and night to ensure patient safety and quality. So what we should do is we should communicate about all the data that is coming in a manner that is understandable to them. And we have created dashboards. We do not just go and present the raw data to the staff. We discuss with them that this is the area that needs improvement. This is the area that this unit has improved, like on hand hygiene. There are hand hygiene champions based on the data that is presented to the staff. So we have created some dashboards. We have put the data in the form of run charts for the staff to understand. And we also do a hospital-wide quality improvement session where we discuss the incidents, we discuss the sentinel events, we discuss all the data about, certain IPSDs. So each and everything is communicated to the staff so that they are also aware.
Awesome. Very important, because sometimes it's like data lives in quality department, right? And doesn't really belong to the people who create the data every day. So I love how you found a way to have those meetings, to have those conversations, and make the data live with the teams that create them. Very good job, everybody. So now we're going to go change gears a little, and we'll talk generally around themes, right? And we'll try to hone in on some of the conversations we started. The first theme we'll be addressing is culture and communication. And please, the other panelists, feel free to interject, even though we have like a panel leader on that theme. So for our theme on culture and communication, Sadia, you lead this conversation. And what are some of the signs of a healthy safety culture? And how do we as leaders model it?
Okay, another very impressive question. So when you want to see a culture in an organization that speaks for patient safety and staff engagement, you can see a security guard stopping a surgeon to get out of the OR in the whole scrubs. And this is a true example for us because, that surgeon, he himself shared the story that I was stopped by the security guard and I said, "Thank you, sir. Thank you for stopping me here." And then the nurse who can stop any surgeon from stepping out of the theater before performing the sign out. If a surgeon, and how do we model that? We create visible leadership. We set an example by listening actively, and not only listening actively to the concerns of the staff members, but also to act upon those. When they're assured that all their concerns are heard and they're acted upon, they'll definitely get engaged. So I think that's how you demonstrate a culture of safety and staff engagement, when there is a visible demonstration of each and everything in the leadership, embedded in the staff as well as the leadership. Thank you.
I mean, I'm going to throw a question at Dr. Ife, Dr. Adejare, just because something she said brings up an important conversation that, when we had the JCI auditor around, she says one of the most interesting patient safety issue is when you have independent consultants who are not necessarily employed by a hospital come in, and how you make them adhere to your safety guidelines. And as a CMAC, right, I want to ask what your experiences have been with that, and how have you been able to promote that culture of safety, even when you have independent consultants coming to use your OR and do things like sign-outs and things like that?
Well, thank you very much. I'd like to say that you're right, that it's a problem. It's definitely easier for your in-house team to align with the hospital culture, but it's also very important to ensure that visiting consultants align fully with your culture. I mean, so onboarding is extremely important. To let anybody who is coming in know that this is how we behave here. So please comply. Then you've got to empower your teams, your OR nurses, for instance. They've got to be able to say, "Oh, you can't go on, sir. Surgery cannot start until we do the necessary steps." And once you maintain such standards, it's not likely that people coming from outside would want to breach your protocols. It can happen. Obviously, if it does happen repeatedly, you might have to take steps.
Yeah.
But I tell you that the vast majority of people don't want to get to that level. And so, I mean, once you've had a conversation or two, that tends to end such behavior.
And an important thing about modeling is it's one thing to empower them to stop. But of course, we know how it is. The next thing, he picks up the phone and he's shouting, "Dr. Dejeri, can you imagine?" The other thing is to show up and reinforce and say, absolutely, she has the authority to stop you because you haven't done what you're supposed to do. We run a system, and just like you said about onboarding. So, as CMO, when I have conversations with independent consultants, because our pharmacy is a big stop in our antimicrobial stewardship campaign. So it means if you prescribe what they don't understand, they will not dispense it. So I always tell them, prescribe cefuroxime for your URTI patients. The pharmacist won't dispense it. And if they call me, I will reinforce it so that you understand that accountability is not just about calling me and I'll override it. It starts with you. So, and we also give them a competency assessment, and we'll say, your antibiotic stewardship is also part of our decision to retain you. It's part of our decision making if we're going to ask to renew your contract. So, I mean, those are kind of some steps that you can take to reinforce what your frontline staff are saying to the team. So,
I'd like to add on to this.
Oh, please go ahead.
Yeah, I think one of the other things that we don't discuss, and maybe it's brought about by the challenges we face in emerging markets, maybe in talent acquisition, is from the onboarding process. As leaders, we should be bold enough to take the steps and determine whether this is the right person you're bringing in. Are they aligned with the philosophy? So in Evercare as a group, one of the philosophies that we have all the way from our private equity investors is not finances, it's actually patient safety and clinical outcome. Now, when you're onboarding, does this individual actually understand what that means? Are they aligned with that? Now, is it a matter of desperation that you would like to cover this gap, or would you be willing to actually hold off and find the right person for the right fit? So onboarding and recruitment and the strength of your HR is something that should also be considered when you're looking to inculcate a culture in an organization.
And you bring up a very important point, because sometimes, you have that shift to fill and, pressure. Very interesting story. A year ago or so, we did an interview and we had a pressured hire for a nurse. And during the interview, for me, I could see that she was going to have behavioral issues. But I let the managers make a decision. I was like, what do you think? They were like, we really need this nurse. I was like, you realize this nurse is going to be problematic? They were like, yes, but we think from the pre-employment screening at the facility, she was rude to her colleague. I was like, I told you. Eventually, down the line, we had to make another decision. But this was something we saw at the interview. But sometimes the pressure pushes us to hire somebody. But we probably should have waited. 2 more interviews would have been hard, paid more overtime, but at the end of the day, got somebody that was a better culture fit. So thanks so much. Does anybody have anything else to add with regard to this?
Because culture is so important and integral to what we do. We have culture champions also. What we did recently was to staff, we organized ourselves, we came up with 4 focus areas: patient experience, culture, quality, and then that's excellent culture, and then great place to work. And we now said every staff should join a group he or she is interested in. And there are people that have chosen to make Evercare a great place to work. And that team have come up with something that they feel if we do this, Evercare will become a great place to work. And fortunately, later become a place where great people want to work. Now, there is a group that is focusing on culture. And that group are now the culture champions, and we run our culture clinic. And because of that, if you do anything that is contrary to the culture, we have agreed as a family, you are going against the norms and rules we have set, and it will be reported as a serious incident.
Absolutely, that's fantastic. And maybe the last question I want to ask around communication is this, Adia. Do we still see any barriers to open communication? And what do we do to overcome them when we see them?
So yes, there definitely are barriers. As Eric has talked about incident reporting, so I'll take that example. Some of the staff members are very, very reluctant to report incidents because they feel that whenever they'll report, something bad will happen. So we need to change the culture of blaming individuals to improving systems. So what we do is whenever we take any sessions, whenever we go on the ground, we conduct leadership walkarounds, and through those leadership walkarounds, we let the staff know that this is not to blame anyone. You can raise any concern. We have open door policy. You can come to the senior leadership team, even the COO, if you have any concern or something. So they do feel reluctant because of maybe their ideas will be judged if they want to improve any process. So they feel like if they're juniors, maybe the seniors won't take it seriously. If they report anything, they will be blamed. So things like that happen, but they need to continuously be ensured that whatever they're speaking up would be, maybe kept confidential. As if we talk about incident reporting, we have introduced a system where they can report anonymously. There should be open reporting channels for them to report very freely and without the fear of taking the blame.
Reprisal. Does anybody else have anything to add to that on the panel? Penina?
Yeah, maybe just to add something on communication, because communication entails quite a lot in when it comes to healthcare. So even the basic, communication between departments, it's something very key. And if you look at statistics, you'll be able to see that out of the IPSGs or International Patient Safety Goals, the most poorly performed is actually handover, which falls under communication. So you may want to know exactly what is this handover about. It's just for continuity of care. So if there's any communication breakdown between a doctor and a nurse, the sufferer is the patient at the end of the day. So it is very important that we are able to communicate to each other clearly and also documenting at the same time. It's not just about talking, but just putting down what you're talking about. That's what I wanted to talk about.
It's so interesting. A lot of us have been talking since we were 1 year, and still communication skills are one of the most crucial parts of patient care and one of the most important aspects that we leave behind, right? Eric, did you want to say something? You were looking like you had some very profound thoughts. Does anybody else have any contributions? Awesome. So we're going to go another way, and we're going to segue into operations management and systems. And Eric, if you'll help me anchor this theme, we'll start by this. Now, how can operations teams make the workplace safer? From staffing to even making sure equipments are reliable.
One of the most important things to ensure that you're successful in a leadership position and you're looking to implement anything, be it a culture of safety, a culture of respect, a culture of patient experience, is to actually co-design this culture with your team.
Absolutely.
Right? So if you want to operationalize anything, it's important that you actually co-design that idea with your team. This means that you have buy-in, you have understanding. They're able to tell you from a design perspective, we interact with this person this way, we interact with this machine this way. This is where we've seen the gap, and this is why the constant breakdown happens. If we were to be provided with this training, we would be able to perform better. However, if it is a top-down approach, then you have an idea that has not been bought. You will face a lot of resistance. And we go back to the lack of reporting. So, you will find a machine that is down. When you're looking at your financials, you ask, why has the CT numbers dropped? And someone says the infusion pump broke down 2 weeks ago. And when you follow up, they'll tell you, but we were not involved in the decision to bring in this machine, so it has nothing to do with us. So it's very important, in my opinion, to ensure that you actually involve the Gemba, the people on the floor shop, in this decision. But there's also governance that is required. You need to have the different governance structures within the organization to ensure that this actually is operationalized. So these will give you the guidance, they will give you the strategic view, but you will also be able to bring out the committees. So if you look at Evercare, which is the beauty about the platform here, is that across the facilities, you will find that we have common committees. I think we have about 15 different committees, morbidity and mortality, etc., cutting across this. And what this means is that we are able to actually utilize this governance structure to be able to operationalize what it is that we're looking for. We also work quite a bit with dashboards, and again, this is across the 3 facilities. This allows us quite a chance and an opportunity to make data-driven decisions. Now, this also allows us to be able to sit with our staff and say, this is the trend, this is what is happening, what do you think we can do to either correct this, enhance this, or implement this decision? I think one major thing that we should also do as leaders, and I've experienced this and I've done this for quite some time, is rounding. It is important that you round and understand what it is your staff are going through. Rounding allows you to be able to be close again to your staff to understand, hey, today we told you that our OPDs were busy, but you were looking at an Excel sheet that said you did not meet budget, so you were not busy, right? But you just have to go down and realize it was one computer that broke down that meant the billing team no longer was able to actually manage the queue well. And this was the stress factor. You go down and you find out there's an equipment that is probably has slowed down. It's not working well. How do you then get the support and necessary teams in to assist? So utilization of technology, doing your rounds, and just working with your staff is actually the best way to operationalize your strategies related to patient safety in your hospitals.
Awesome. And I love how you talk about Gemba, because we also implement Lean. So we talk about Gemba a lot. Go to the floor. Don't just sit there and assume that you know what you know. Let the people who are actually doing the work tell you what they know, right? And how to make things work. Does anybody else have some thoughts on what Eric has talked about?
Yeah, just to piggyback on what Eric's mentioned, it's very important for operation teams and the clinical team to work hand in hand if we're going to ensure patient safety. It's mentioned equipment, that's very critical. Things happen. We've got to escalate quickly to the operation teams when critical equipment break down, because they affect patient outcomes, satisfaction, safety, which is all we're really, really in business for.
I mean, I understand what you mean. I remember, we have like PPM lists, and for the long time we have critical equipment downtime. For the long time, our defibrillator uptime. Then something happened. I think either it was a Gemba walk and somebody turned on the defibrillator and it was dead. And it was like, oh, well, yeah, if you plug it to the wall, it works. but yeah, the battery stopped working a year ago. I'm like, who knew this? Like, all the nursing team knew this. Did you tell the operations team? Absolutely not. Because when you plug it to the wall, it works, right? But when there's an emergency, you may not see a socket to plug it into. But there's that, disconnect, and getting those teams to talk to each other is extremely important. Anybody else? Go ahead.
I think to piggyback on that is one of the other ways of operationalizing patient safety is the continuous education. So you see in that case, they did not assume if the power goes, what happens, right? So where does the education come from to understand the importance of having a risk register or risk management?
Exactly.
So continuous education, and I think one thing I completely forgot is, we're human, so we want to be incentivized, we want to be recognized, we want to be appreciated. And, doing this publicly in your town halls, in your daily digest or your monthly digest goes a long way in ensuring that people actually then start operationalizing what they believe in.
Awesome. Thank you so much. I'm just going to switch gears very quickly. Dr. Adejare, are you ready for me? I'm going to talk a little about data and learning. And
I'm sorry, I didn't catch that.
are you ready for me? Awesome. So, have you had any adverse events? Have you taken any lessons? And how do you ensure that it's lessons and not blame?
Thank you. It's a hospital.
Yeah, of course.
So there will be adverse events. You want to keep the numbers low. Ideally, you want to achieve 0 adverse events. That's near impossible.
Mm-hmm.
So how do you ensure that it's a no blame game? I think the key point here is to have an open communication channel. First of all, have the mechanisms to ensure that staff can report the adverse events. And what would encourage staff to report events is when they are not afraid that somebody would be blamed or unnecessarily for the event. Now when we create that culture, that will encourage people to bring up these adverse events. And once this is reported, obviously, then it has to go through the process of being thoroughly investigated and CAPA performed so we can tell what's happened, why it happened, what steps do we take to mitigate these, and then begin to implement those steps. That's the kind of process that will ensure that even though an adverse event has happened, you can prevent another one or a similar one from happening. And that's essentially the process of quality improvement in hospital systems.
Absolutely. I see one thing that has helped me is, so I make the person involved part of the root cause analysis. And what we do, I know how the root cause analysis, if you're doing fishbone, I always say we're not going to talk about people. We'll talk about systems, we'll talk about policy, we'll talk about technology. The last thing we'll talk about is people, right? Because sometimes the temptation is we don't have enough staff, or this person did not come to work, or this person forgot. I like to believe that healthcare attracts reasonable, rational, and decent people. And if a reasonable, rational, decent person made a mistake, it was not intentional. So what have we created in the system that allowed this reasonable, rational person do something that resulted in this bad outcome, right? So I always put people off. You cannot say anything about people. You say it at the last possible thing. Because yes, sometimes it's a people problem, but why is that reasonable, non-psychopath doing something that have created this severe adverse event, right?
Yeah, just to add to this, Dr. Effie, you see, underreporting is a big issue.
Yeah.
I would just like to mention an example of my hospital that there was a sentinel event, And then during the root cause analysis, we found out that we don't have a second victim policy, because the staff who was actually involved was feeling very underconfident, was full of fear, thinking that if whatever situation has happened, is it because of him or her? Would any action be taken against her? So that is why then it was an area of improvement for us, although we tried to do it in a much more professional and a neutral way. But then we went back, sat with HR, and then we started working on our second victim policy. So yeah, this is also something that is important, because that will actually help us in improving our incident reportings and adverse events and sentinel event.
Yeah. And having a known blame culture is very hard, because the temptation is to say, put the person on the wall. I mean, our incident system, we say incident, we have to put posters, incident is no blame. So it means if an incident is involving a staff, is reported by the staff, we can't fire the person. It's hard, but that has transformed the ability of people to report incidents, because there are obvious examples of when somebody has reported an incident about themselves, right? Because if somebody has reported it, has thought about a corrective action, and thought about a way to make sure it doesn't happen again, that is accountability. That's all we can teach, right? People are humans, they will make mistakes, but if they're accountable, then the chances are they won't make that mistake again. So we'll take our last, and Uzair, since you're already there, I'll just keep it with you. And maybe just ask a question. Like, what's the one leadership behavior that most influences safety culture at your hospital?
Admitting that you have made a mistake. As simple as that. Because we as leaders need to be vulnerable as well sometimes. We need to sit in meetings and say, yeah, I don't know this. As soon as you say that, there's enough psychological safety in the room that the people can get relaxed, and they started saying any issues or gaps that come along. So this is something that I've learned, and I've recently learned it through the training program that we went through. So yeah, it has been quite transformational for myself.
I mean, it's so important. I mean, I lead a team, I'm a physician, I lead a team that has accountants, engineers. I don't know anything about, certain things. My accounting knowledge is still basic to intermediate. So imagine if you go into a meeting with accountants and think that you know everything. Absolutely, you're going to come out of that meeting not having learned anything. So having that vulnerability as a leader, that you don't know everything, and your teams have a lot to teach you about how they work and how they make improvements. So before we finish, because I feel like you guys are so loaded, people need to be able to ask questions. If we have any questions in the audience for my amazing panelists, please show by raising your hands, and somebody will bring a microphone to you. I'm depending on them to find you because I'm not wearing my glasses. Questions, comments?
Yeah, Dr. Ife, thank you. This has been a wonderful session, and great job to everyone there. I heard a lot of, striving to encourage people to report safety incidents. And in the process of doing that, removing the disinhibition, basically from doing that, almost makes you avoid punitive or corrective action. It's a very fine line to toe, because in organizations, there has to be some level of repercussion, especially for repeated behavior, or at least a discussion to say, how do we do this, or performance improvement plan. So how do you balance that, where you want to be friendly enough to have people feel safe to report, but you also have to be accountable enough to share that a mistake happened? Because sometimes in medicine, we don't have the luxury. It might not be a small mistake. Yeah. This could be something that results in patient mortality or death. So how do you balance that?
Does anybody want to take that?
Yeah, if I may. creating a culture where incidents can be reported should not condone repeated mistakes. Yes. What we are saying is a situation where people learn from mistakes should not encourage people making repeated mistakes. We should also be careful because it's a balancing act. We shouldn't instill fear in people. Otherwise, they won't be innovative. But what me as a person will not support, because the job we do is that any small thing, people will die. And we don't want that. So what I should encourage is that people should be allowed to report mistakes, but we should not condone repeated mistakes.
Completely agree with Peter. The additional point I was going to make there is that there obviously will be certain mistakes that are really egregious, and you may not be in a position to give a second chance. I think we should also all realize that. But obviously, I agree with Ifunaya's policy of starting by saying, you know what, we would not
talk about people,
punish, in quotes, at the first instance. I think that would help with incident reporting a lot. The no blame policy is extremely helpful.
Yeah.
Go ahead.
I want to add into that. There has to be, it's very true that we have to balance between, an punitive versus just culture. And for me, I look at it from a very different angle. You've done all the training, you've put up the proper systems in place, and people have made mistakes, and you've taken it okay, and you've gone through the root cause analysis, and you've given them psychological safety to work with. But things are not working. There must be a part where performance management comes in.
Of course.
For you to be able to say that we have done everything that we needed to do to help you work and deliver results, but it is not working. And there has to be that very difficult discussion that you have to have with the staff. And, it's okay to shake hands and say it was nice working with you.
Yes.
Yeah? But it has to be very well done with a lot of respect.
And just like everybody has said, the incident management does not replace performance management. Absolutely. Right? Of course, as much as we have no blame cultures, we have had to let staff go for serious infractions on patient safety. So it is a balancing act. In a lot of those cases, it's an accountability issue. They're either incidents that they hid, and then we uncovered them after many root cause analysis. So it's a candor issue as well. So it's medicine, and as evidence-based as it is, it's also not exactly an exact science all the time. So we must give space to the fact that we're hiring new nurses, hiring new doctors, they're learning, and they will make mistakes, and how do we ensure that those mistakes are corrected and not repetitive? So Eric, you wanted to say something?
Yeah, I was going to reiterate what Penina said in terms of the handshake, but I think one thing that we tend to overlook is the communication of the decision that has been made.
Yeah.
Right?
Absolutely.
So if people are afraid to speak up and someone spoke up and we went through this process and they were terminated, then the natural inclination of the people is to retract. Right? So I think it's also important that we close the loop respectfully and talk about what happened, why the decision was made, and what we are doing proactively to correct it. So that people still get the feeling that, yes, you can speak up. However, there is a level of zero tolerance when it comes to hiding incidences under your car and things like that. So there is that loop we need to close, but if the handshake is necessary, the handshake shall be done.
Yeah. Can we take, please, I know we're out of time, one more question very quickly before I know we're holding everybody hostage to go for lunch.
Thank you for the opportunity to ask the question. I'm a surgeon, so I'm talking from that perspective. For example, a certain number or a percentage of wound infection is totally permissible, but that you are only going to know if you have a clinical audit. So is there any policy in your hospitals that you have sort of implemented of encouraging clinical audit? Because it will be like you have to keep on looking at your own complications, keep on seeing what you're not doing right, how can you improve, and rather than when suddenly something very bad happens, then everybody jumps in.
Absolutely.
So that's the question.
Let me speak to that. You're right. Clinical audits are a very important tool to identify problems before, or patterns rather, before a big incident happens. And at Evercare in Lekki, we recently, that's in the past maybe 5 months or so, commenced as the medical advisory committee clinical audits in each department. Several departments have completed their first set of audits, which are like pilot programs. Let's have basic background information on what's happening in our hospital. For instance, as a surgeon, we looked in our department at wound infection rates in comparison with what you're seeing internationally and with hospitals outside of Evercare that are local. And that gives us basic background information. So if Dr. X joins the team and he's doing appendectomies and he's getting different rates from the team on ground, then we have to ask why and how do we make Dr. X measure up to our standards. I mean, that you're absolutely correct.
Absolutely true. Can we put our hands together for my amazing panelists? I promised you they were much smarter than I was. Thank you so much. So, final reflections, 30 seconds. What can everybody here take away? Sadia, starting with you.
So the takeaway is for us, the culture of safety begins right from the top, and you cannot tell the people to follow the policies. It's not about policies, it's about people caring for people. So
awesome. You can't give what you don't have, right? Eric?
Yes, culture of safety is leadership presence, it's visibility, but again, it is also a space where people feel that they're appreciated, responsible, safe, and able and empowered in order for them to be able to make the changes that they aspire to.
Awesome. Uzair?
Yeah, so I think culture of safety is more of a journey rather than a destination. We should never be settled, we should never be complacent, and we need to keep forward improving our systems and processes, yeah.
Absolutely. Panina?
For me, the most detrimental thing is not to make a mistake. It is failing to learn from a mistake.
Amazing. Dr. Adejari?
Yes, in my view, it's it's everybody's business. That's the primary reason why we're in the hospital. 2, we should work together as a team, learn to communicate. 3, those who are in leadership should lead by example.
Amazing. And finally, Peter?
Yeah, the major lesson is that a patient is a human being. It could be any of us. It could be our son. It could be our daughter. It could be our parent. It could be anybody that related to us. If we don't keep everywhere safe, if we are not careful, we will lose one of them.
Amazing. So the message today is clear. Safe care depends on engaged people, and engaged people depend on trusted leaders. Let's continue to build systems where safety isn't enforced, it's embraced. Thank you, everybody. And I think you can go for lunch now, but I think we have to take a picture first. So please, thank you so much for being on this panel. We can quickly get the picture.
Thank you, Dr. Rifi. Thank you to our wonderful panelists as well. If I can call on Tosin, our chairman for the Lekki board. Peter Osuji. Dr. Ifidayo. Uzair. Penina. Eric. Sadia. And to our wonderful moderator, Dr. Ifi. Okay, so we're now going to move on to lunch, but before we do so, Abiodun, what are your dance moves like?
What do you mean?
So as part of lunch, we have a cultural dance presentation.
Okay.
So please enjoy, join in to the cultural dance presentation while you're enjoying your lunch.
Yeah, and as we come back, so we're going to be having the experts talk audiences come and remain in this room. And the audiences for the insurance talks, please proceed to the room 2 upstairs. You have the ushers in black, they will guide you. And also after the insurance talk upstairs, we are going to be having the audit talk by Jawad. So insurance will be held by our Head of Revenue Cycle Management, Evercare Hospital Lekki, Buchi Uchela, alongside the 3 CEOs, Leadway, AXA Mansard, and Bastion. So if you are for that session, after lunch, at 3:15, please proceed to the room 2. Ushers are there to guide you. And now as we proceed for lunch, please, so that we do this orderly, we're expecting the top rows to move with our ushers to the dining room. So please proceed. The front rows, please, first, so others can remain while the front rows proceed to the lunch area. Thank you as you comply. Okay, so the next row after that. Yeah, the next row, please proceed for lunch. And I would like to say to our streaming audiences, our virtual audiences, we are going to be coming back by 3:15. So the next row. Thank you as you comply. So the next row. Okay, the next row, please. So the remaining rows, you can kindly also be orderly while you approach the lunch area. Thank you for complying.
starts to cry. The lady wants to know.
I was asking Ibo kwenu. Ibo kwenu. 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 Hey, 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 hey. Hey, hey. Oh. Medio, metoye di medio, metoye di ma, iye mi monyo, metoye di ma, makadudo, metoye di medio, metoye di medio, metoye di ma, iye mi monyo, metoye di ma. Makagino, 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 makadudo, makagino, makadudo, oh no. Hey, hey, hey.
We say a big thank you to the Wazobia performers. So just to put a brief background to that, to the Kenyans and to the Pakistanis who may be wondering what's happening. So they have just tried to summarize the culture of the entire country, Nigeria. In Nigeria, we have officially about 250 ethnic groups, even though some studies says it's more than that. But they have tried to summarize everything into 7 performances, which we've just seen now. In Nigeria, we have 3 major tribes, but over 250 other ones. We have the 3 major ones, which are the Yoruba, Hausa, and the Igbos. So, but now, they've shown us a beautiful performance, showing us the cultures across the country. Thank you for enjoying that. I know everyone enjoyed it. Professor Assad, we saw you dancing. You had fun with that. All right, so we move straight. Just to inform you again, the health insurance talk is currently going on at the room 2. We have the 3 CEOs from Leadway Health, Bastion, and Axel Mansard organizing that. And immediately after that, at the room 2, we are going to be having the internal audit discussions being held by Jawad Kazi, the Group Finance Director, Evercare. Thank you.
So to continue our talks in this room, we would like to welcome Dr. Cole Benson, First Vice President of the Healthcare Federation. A very warm welcome.